Hello and welcome to the rapid fire revision of OBS and Gynae for upcoming FMGE exam in Jan 2024. So welcome you all for this rapid fire revision of OBS and Gynae. I have specially planned this session just before the exam because it is going to be very high yield for your upcoming exam, and I am expecting many of the points, the questions can be asked in this upcoming exam of FMGE Jan 2024. This is going to be beneficial for the PG aspirant students as well. So welcome you all and good evening everyone. So myself Dr. Harmeet Goel, I am your OBS and Gynae faculty. So presently I am working as a consultant gynecology in Preventive Oncology Department of Rajiv Gandhi Cancer Institute and Research Center, Rohini, and I am teaching faculty at LN. So this is the live session for you, and any of your queries are welcomed in the chat box. You can keep on writing your doubts. So welcome you all. So I am taking up the gynecology revision first, and here my main aim is to take a topic wise discussion. What are the important points on which the FMG exam questions have been asked, and it is going to be very fruitful session for you. So I have added up in the form of fill in the blanks, single liners, images, image based questions and high yielding points topic wise. So I am starting with gynecology revision first. So my first point of discussion is the topic ectopic pregnancy, which is very expected. Yes, Dr. Neha, I will definitely tell you the management of cancers. I am starting up with ectopic pregnancy. So friends, ectopic pregnancy, as all of you know, is implantation of fertilized ovum occurring outside the uterine cavity, and most common site for ectopic pregnancy is the fallopian tube. Around 97 to 98% of ectopic pregnancy occurs in the fallopian tube. Why? Because fallopian tube is the most common site for fertilization. Now, which part of the fallopian tube ectopic pregnancy is most common? So, the part of the fallopian tube where the ectopic pregnancy is common is the ampulla. That is the widest portion of the fallopian tube. It is 5 centimeters, and this is the normal site for fertilization as well. Now, which type of ectopic pregnancy ruptures earliest? Earliest to rupture is ischemic ectopic pregnancy. It ruptures in less than 6 weeks because this is the thinner portion of the fallopian tube, and the fallopian tube does not have, the cells in the fallopian tube do not have the power of hypertrophy and hyperplasia. So when the pregnancy is developing in this part of the fallopian tube, it is likely to rupture, and usually the patient may come up with amenorrhea, pain, bleeding and fainting. Now, the narrowest portion of the fallopian tube, do not get confused, narrowest part of the fallopian tube is always the interstitial part, which is 1 mm in diameter. Okay, so that is also an important point to remember. Earliest to rupture ectopic is ischemic ectopic, and narrowest part of the fallopian tube is interstitial part. Now, late to rupture ectopic pregnancy is interstitial ectopic pregnancy. Interstitial, it may take 3 to 4 months to continue because this type of the ectopic pregnancy may grow in the towards the uterine side, and it might be missed out on the investigation. Okay, and we might take it as a normal uterine pregnancy, but actually that is an ectopic pregnancy. Now, which type of ectopic pregnancy is considered as the most dangerous type of ectopic pregnancy? Yes, I can read your answers. Dr. Rathore, Dr. Subhashri, Afreen, then Dr. Ravi, Dr. Neha and others. So it is very correct answer. The dangerous ectopic pregnancy is interstitial ectopic pregnancy, because you know, like, this is very vascular part of the female genital tract, and you know, like, if this type of ectopic pregnancy ruptures, it may land up in the hemoperitoneum, and at times we might have to take up the patient for hysterectomy if hemostasis has not been achieved by conservative steps. Next, classical triad for ectopic pregnancy, always remember, is amenorrhea, pain and bleeding. If it is written as fainting, that is not the classical triad, because the ectopic pregnancy may present as an unruptured ectopic pregnancy as well. Now, the type of ectopic pregnancy and what is the name of the criteria. Type of ectopic pregnancy and name of the criteria. For ovarian ectopic pregnancy, the criteria is Spiegelberg. So any of the student who is writing the NEET PG exam or INI-CET exam and attending the session, let me tell you, this session is going to be useful for them also, because these criteria are mostly asked in the PG exam. So ovarian ectopic pregnancy, the criteria is Spiegelberg. For primary abdominal ectopic pregnancy, the criteria is Study Ford, and for cervical ectopic pregnancy, the criteria is Rubin's criteria. Fine. So ovarian ectopic pregnancy, the criteria is Spiegelberg. For primary abdominal ectopic pregnancy, which is very rare, the criteria is Study Ford, and cervical ectopic pregnancy, the criteria is Rubin's criteria. Next, which is the best non-invasive investigation to diagnose ectopic pregnancy? Friends, always remember, it is transvaginal scan. Okay, so best non-invasive investigation, if a patient presents with amenorrhea, pain, bleeding, the best is to send the patient, do a urine pregnancy test first, do a clinical per vaginum examination first, make your provisional diagnosis and send for an investigation which is transvaginal scan. Now, transvaginal scan will write like empty uterus, that is no gestation sac in the uterus, and there may be adnexal mass. If they write cardiac activity present in the adnexa, then you can make up a diagnosis of ectopic pregnancy, but most of the time they just write empty uterus and adnexal mass, which is likely to be an ectopic, but they do not comment, the radiologists do not comment upon ectopic pregnancy. So which is the best combination of investigation in such a case is transvaginal scan plus serial beta HCG level. Mind it, this combination of investigation is only applicable for the stable patients. If it is hemodynamically unstable patient or a patient has presented with ruptured, that means rupture ectopic pregnancy, there is guarding, rigidity present, fullness in the pouch of Douglas, then in that case you will not send the patient for a beta HCG. Moreover, your diagnosis is mostly a clinical diagnosis. If you can perform very quickly a bedside ultrasound, that will be very conclusive of the ectopic pregnancy. Now, findings on ultrasound suggestive of ectopic pregnancy, I have already mentioned empty uterus and adnexal mass. In the adnexal mass, it is cardiac activity present in the adnexa, then it is more likely to be a case of ectopic pregnancy. Now, what is the gold standard investigation in case of ectopic pregnancy where your diagnosis is under suspicion? The findings of the ultrasound is not consistent, okay, or not, it is very clear cut finding of ectopic pregnancy, okay, and patient's blood pressure is 90/50, or you know, like maybe she is having severe pain abdomen, okay, and the investigation is not giving you fruitful you know, like diagnosis of an ectopic pregnancy, we might take the patient for a diagnostic laparoscopy, taking the consent for the therapeutic laparoscopy as well, or followed by laparotomy if you are not able to manage the case with laparoscopy. So this is an image which is showing that this is the uterus, this is the fallopian tube, and can you see this mass in the fallopian tube? This is unruptured ectopic pregnancy, and this diagnosis can be made Confirmation of diagnosis can be made on laparoscopy followed by therapeutic salpingostomy. So, with one investigation we have confirmed our diagnosis and simultaneously we can provide the therapeutic measure, which is salpingostomy. Next, maximum chance of developing an ectopic pregnancy is previous tubal surgery, multiple MTPs, IUCD insertion or previous ectopic pregnancy. Frankly speaking, all of these are the risk factors for ectopic pregnancy. All of these are risk factors for ectopic pregnancy, but when do you call it as a maximum chance for developing ectopic pregnancy? Your answer should be previous ectopic pregnancy. So, I will be discussing the concepts, very crisp and rapid concise revision of whole of OBS and Gynae subject, okay, and in between I will keep on adding up the important MCQs as well, okay. So, it is going to be a very fruitful session for you. So, previous ectopic pregnancy, there is highest chance for ectopic pregnancy. If you are asked which is the most common cause for ectopic pregnancy, then what will you mark? Why I am not taking just straight MCQ session, because that I have already taken test and discussion of OBS and Gynae, guess questions for OBS and Gynae, as well as 5 years PYQs of OBS and Gynae that has been asked in last 5 years of FMGE exam. So, you can go through those videos if you have time. So, most common cause for ectopic pregnancy remains PID, that is pelvic inflammatory disease, which is mostly the ascending infection. Next, patient was brought to the gynae casualty with a history of 6 weeks amenorrhea, severe pain abdomen and bleeding. Severe pain abdomen, bleeding and fainting, BP recorded was 80/50. What is your diagnosis and management? You can write your answers in the chat box. I can read your chat. Yes, Dr. Shekhar, Dr. Simranjeet, Dr. Afreen, I can read your answers. Dr. Priyanka, all of you are correct. PID is pelvic inflammatory disease, that is the most common cause, because that ascending infection can cause damage to the cilia of the fallopian tube and the fertilized ovum can stay there and leads to the chance for ectopic pregnancy. Now, in this case, this is a question which is a clinical presentation of a patient, because I am going to make you practice very quickly and very fast and rapid revision of the clinical questions as well. So, this is, yes, all of you are right, this is a case of ruptured ectopic pregnancy. You can do a urine pregnancy test, very quickly it comes out to be positive. You can do the parvaginum examination where you can find fullness in the pouch of Douglas. Fullness in pouch of Douglas, uterus appears normal size and there is lot of tenderness. If you can do a transvaginal scan very quickly ka bedside, that will tell you 100% very sure shot, but this is most of the time a clinical diagnosis of amenorrhea, pain, bleeding, fainting and BP 80/50. On examination, uterus normal size and there is tenderness in the adnexa or in the pouch of Douglas. Now, what is your management in this case? Management in this case is always, first line is resuscitation. Revive the patient from shock, start the IV line, take the blood sample. You have to arrange blood, start IV line, start ringer lactate drip, arrange blood, take the consent and shift towards immediate laparotomy. Because when it is a rupture ectopic pregnancy, there is no wait and watch, there is no second thought about sending the patient for a serial beta HCG because patient's condition is unstable. So, management is resuscitation followed by immediate laparotomy by arranging the blood. Resuscitation followed by immediate laparotomy, arranging the blood. Okay. After doing the immediate laparotomy, you have to do the salpingectomy. Look for the, do the suction. If there is any blood loss in the peritoneal cavity, then look into the damaged fallopian tube, apply clamps and do the salpingectomy. So always remember, the management of rupture ectopic pregnancy is resuscitation and immediate laparotomy followed by partial or complete salpingectomy. Next. Now you have to identify what is this image showing. What is this image showing? I am still discussing the topic of ectopic pregnancy. What is this image showing, friends? This image is showing culdocentesis. So you will be given a history like amenorrhea, pain, bleeding, maybe fainting, and this image is given. You can see this is the uterus, this is the pouch of Douglas, and in the syringe blood is aspirated from pouch of Douglas. So this is culdocentesis. A diagnosis of rupture ectopic pregnancy can be made. Next, if it is unruptured ectopic pregnancy, that is amenorrhea, pain, bleeding, and vitals are stable, you have sent the patient for an ultrasound after doing the examination, plus you have sent for an HCG, and you have arrived at a diagnosis of unruptured ectopic pregnancy. Now, what are the criteria to offer the patient a medical management or a surgical management? In the medical management, the drug of choice is methotrexate. Drug of choice is methotrexate, and you give it by intramuscular route, that is like per kg body weight, that is the dose of the methotrexate. And for the surgical management, you can go for a laparoscopy or laparotomy. Laparoscopic guided surgery or for laparotomy. For the methotrexate, the size of ectopic pregnancy less than 4 centimeters, cardiac activity should be absent, beta HCG should be less than 5000, patient should be hemodynamically stable, and family is not complete, that is points favoring towards the medical management. Very important criteria for a medical management is cardiac activity should be absent. This criteria they have already asked in FMGE exam 2015, and they have asked definitely in the PG entrance exam. Okay. Now surgical management. Surgical management, if the size of ectopic pregnancy exceeds more than 4 centimeters, cardiac activity is present, beta HCG is more than 5000, patient is unstable or family complete, you can go for a surgical management. That if it is like patient is not in shock, vitals are maintained, so you can go for a laparoscopy, otherwise laparotomy. Usually students, this is in these type of questions, usually they don't ask about laparotomy or laparoscopy. If the patient's condition is stable, we go for a laparoscopy. If it is unstable, it is in shock, 80/50 BP, we will definitely go for laparotomy. Okay. Yes, this exam will be, this video will be there. All of my previous videos of the 5 years PYQs, test and discussion of OBS and Gynae, guest questions of OBS and Gynae, high yield questions, all those videos are still there on NExT YouTube channel. You can watch those videos. Now, enough of ectopic pregnancy. So, I am taking up my next topic of discussion, that is infertility. Okay, every time I take up the session, I start up with disorders of menstruation topic. Now this time I decided to start up with ectopic, infertility, and then I will move forward with rest of the topics. Now in this case, in this question, infertility, what is the first investigation to be done in a case of infertility couple? So it is always the semen analysis, because around 40% of the cases, the cause of infertility is the male factor of infertility. 25 to 40% both unexplained infertility. So that can be, if you take an average, 40% of the cases of infertility, the cause is the male factor of infertility. So why not investigate the male partner first? Now most treatable form of infertility is an ovulation, because we have to give ovulation induction agents. Ovulation induction agents. Now WHO cutoff limit for sperm count. What is your answer? I can see your chat box. 15 million per ml. WHO cutoff limit for sperm count is 15 million per ml. If it is less than this, it is called as oligospermia. What is the most important fertility indicator in the semen analysis? Dr. Rathore, it is not 20 million, it is 15 million. Most important fertility indicator in semen analysis is morphology of the sperms should be normal. If that's not given, then you mark your answer as motility of sperms. If that is not given, then you mark your answer as count. So in the AIMS PG exam, AIMS PG, they have asked most important fertility indicator in the semen analysis. Your answer is morphology of the sperms should be normal. Yes, total spermatogenesis is complete in 74 days. Semen in the semen banks is stored under liquid nitrogen. So this is very high yielding revision for your upcoming exams of 2024. Now next. Now let us quickly go through the WHO cutoff limit for semen analysis. In the amount, it is 1.5 ml. In the count, cutoff limit is 15 million per ml. Motility is 40% and progressive motility is 32% and morphology is 4%. Yes, I can see your answers. Most of you have written it very correctly. The morphology, many of you have written correct answers. Dr. Javed has written correct. 74 days is the like total spermatogenesis. 40% is the normal motility of the sperms, that is the WHO cutoff limit. Fine. Next, absence of sperms. What is this called as? Absence of sperms in the semen is called as azoospermia. Absence of semen is called as aspermia. Oligospermia is sperm count less than 15 million per ml and decreased motility of the sperm is called as asthenospermia. Dead sperms is called as necrospermia. Many times they have asked questions in FMGE exam on these points. Okay, so you have to be very clear. If there is blood in the semen, that is something because of the trauma. Next, now can you tell me, there is one syndrome which is associated with male factor of infertility. Very commonly you read that syndrome. What is that syndrome which is associated with male factor of infertility? Can you write down in the chat box? Dr. Priyanka, Dr. Pushkar, Dr. Shekhar, Dr. Rafreen, Dr. H, Dr. Simranjeet, Dr. ZV, Dr. Monica, Dr. Dive. Can you write what is that syndrome which is associated with male factor of infertility? Yes. One answer is Klinefelter syndrome. Yes, but I agree. You have written other syndromes also. Kalaman syndrome, yes. Carter-Jenner syndrome, yes. Kalaman syndrome, Carter-Jenner syndrome, all of you are correct. And microdeletions, that is also correct. Next, so that is why karyotyping is very important at times. Main contributor of the semen is seminal vesicle fluid. Presence of fructose in the semen confirms that seminal vesicles are functioning normally. To differentiate the cause of azoospermia, whether it is pituitary failure, gonadal failure, or there is post-testicular azoospermia. So, what is the test done to differentiate the cause of azoospermia? Gonadal failure, pituitary failure, obstruction, or congenital absence of the vas difference. So there are 4 important points: pituitary failure, gonadal failure, obstruction at the level of vas deferens, or congenital absence of vas deferens. So these levels. So how do you differentiate? I would like to get FSH, LH, testosterone done, as well as transrectal ultrasound to find out it is obstruction at the level of vas deferens or it is congenital absence of bilateral vas deferens. To differentiate, transrectal ultrasound is a very important investigation. Next, DEST investigation can differentiate congenital absence of vas deferens and obstructed agiospermia, that is transrectal ultrasound. Infertility caused by impotence, hypospadias, oligospermia or cervical factor of infertility. What will be the treatment for infertility? If it is a male factor of infertility, cause is impotence, premature ejaculation, severe hypospadias, or anti-spermal antibodies, that is cervical factor of infertility. Now what is the treatment for this? Treatment in this case is IUI, that is intrauterine insemination. Intrauterine insemination. Friends, usually IVF is not done for these cases. IVF is a reserved treatment for tubal factor of infertility, that is bilateral tubal block. It is a treatment in which there is donor oocytes are being used, like in cases of diminished ovarian reserve or premature ovarian failure, or if it is a moderate to severe endometriosis. Most of the indications for IVF or ICSI are the female factor of infertility. For male, yes, cystic fibrosis is another cause for male factor of infertility. Dr. Anup, you have written very correctly. Dr. Randhir, you have written correctly. So I can read your chat. Now let us proceed further. So most reversible form of infertility is anovulation, as I have already mentioned. 40 to 50% of unexplained infertility, the cause is endometriosis. So laparoscopy remains a very gold standard investigation, because we want to rule out endometriosis. So we can go for a laparoscopy. So that is gold standard investigation for endometriosis. So I have already mentioned gold standard investigation is endometriosis, is laparoscopy. And if I have to write the gold standard investigation for uterine factor of infertility, then your answer will be hysteroscopy. Now I am talking about female factor of infertility. I am discussing female factor of infertility now. Okay. So most reversible form of infertility is anovulation. 40 to 50% cases of unexplained infertility, the cause is endometriosis. And what is the investigation? Gold standard for endometriosis or peritoneal factor of infertility. Endometriosis is called as peritoneal factor of infertility because there are multiple adhesions, peritubal, periovarian adhesions. Okay. So fallopian tube is not able to move the fimbriae to pick up the ovum. So hence it is a female factor of infertility, that is peritoneal factor. Now there are images given here for the uterine factor of infertility. So hysteroscopy remains the gold standard investigation. Why did I say? Because you can confirm your diagnosis of Asherman syndrome. This is HSG finding and this is hysteroscopic finding of Asherman syndrome. And here you can see submucosal fibroid or polyp. So hysteroscopy remains the gold standard because you can do hysteroscopic guided adhesiolysis Adhesiolysis in cases of Asherman syndrome, you can write down in the chat, okay, or your comment section that you want a PDF, so that the team of the LN, they are going to send you the link and all, okay. Now submucosal fibroid or polyp, it can be removed by hysteroscopy. So hysteroscopy remains the gold standard investigation for uterine factor of infertility. Next, most important and common cause of cystic ovarian disease. Other causes of anovulation can be radiotherapy, can be Turner syndrome, it can be hyperprolactinemia, that is a systemic cause for anovulation, but PCOD remains the most important and most common cause for anovulation. What is the drug of choice for anovulation? Is always ovulation induction agents. Ovulation induction agents like, better drug is letrozole, which is aromatase inhibitor, which is acting as an anti-estrogen, and the next drug is clomiphene citrate. Now why nowadays we prefer the letrozole? Letrozole is preferred. Letrozole has got less side effects and dose is also less, and conception rates are better. Fine. Now test for ovulation is transvaginal scan or ultrasound follicular monitoring. Ultrasound follicular monitoring. Now size of the dominant follicle is 18 to 20 mm, and you see this on transvaginal scan. Friends, you know serum progesterone is also confirmatory for ovulation. Serum progesterone is done on day 21 of the cycle in a 28 days menstrual cycle, and its value more than 5 nanogram per ml is confirmatory for ovulation. Okay. Next. Now this is polycystic ovarian disease. On ultrasound, what do you see, friends? You can see the necklace pattern of ovaries. Necklace pattern of ovaries, but ultrasound alone is not suggestive of the diagnosis of polycystic ovarian disease. You have to get the hormonal profile done as well. So you should read in the polycystic ovarian disease the Rotterdam's criteria, which is very, very important. Now I am taking up one question. In infertility couple, the female has regular menstrual cycles with normal flow. What test you need to do? Day 14 serum progesterone, day 14 serum LH, day 21 serum LH, or day 21 serum progesterone. What is your answer? What's your answer? So correct answer is D. Yes, you are correct. Day 21 serum progesterone is confirmatory for ovulation. If you can find out the presence of serum progesterone is confirmatory that the cycles are ovulatory. Next, ovarian hyperstimulation syndrome. Why I added up this image? Because you should not get confused with the image of polycystic ovarian disease. You can see this is necklace pattern of ovaries. The cysts are arranged in the periphery. The cysts are arranged in the periphery, whereas ovarian hyperstimulation syndrome occurs when you give ovulation induction agent. Most common drug to cause ovarian hyperstimulation syndrome is HMG injection, that is FSH injection, because it is directly stimulating the ovaries. So which is a drug that most commonly causes ovarian hyperstimulation syndrome? If there are any symptoms like ascites, ARDS, etc., then you have to go for a symptomatic treatment, but first step is always stop any ovulation induction drugs, stop ovulation induction drugs. Now, best test for ovarian reserve is always AMH, anti-Mullerian hormone. Anti-Mullerian hormone, if its value is less than 1 nanogram per ml, that shows that it is poor ovarian reserve. Poor ovarian reserve. Why we do not take up the FSH, inhibin B or estradiol levels while we want to check for ovarian reserve, because that is also the test to check for ovarian reserve. The reason is their value is feedback inhibition dependent. Okay. So, but AMH, which is secreted by granulosa cells in the female, granulosa cells of the ovary, it is a test for ovarian reserve. It is not dependent upon feedback inhibition. Now, next important term, you should know what is premature ovarian failure or primary ovarian insufficiency. Ovarian failure occurring before the age of 40 years is called as primary ovarian insufficiency or premature ovarian failure. There is depletion of ovarian follicles, depletion of ovarian follicles. So, there is no ovulation, estrogen, progesterone are down. So, there is no negative feedback inhibition at the level of pituitary gland. So, pituitary secretes high levels of FSH and LH, high levels of FSH and LH. Okay. So, investigation done to confirm premature ovarian failure includes FSH more than 40 international units and serum estradiol less than 25 picograms per ml. Now, what is the treatment for premature ovarian insufficiency or diminished ovarian reserve? The management for this is IVF using donor oocytes, because these patients are having uterus, okay, but there is no ovulation from the ovaries and the ovarian hormones are down. So, we give estrogen to this female followed by progesterone to make the endometrial lining. Send this for a transvaginal scan to check for endometrial thickness if it is appropriate for implantation. Simultaneously, we take a donor oocyte, fertilize with husband's sperm and do IVF and do embryo transfer. And the pregnancy support is be done for the first trimester by giving progesterone injections or vaginal progesterone suppositories. Once the first trimester is over, then placenta can takes over the function of the like hormonal secretion. Okay. So, I hope it is clear. So, if you are asked what is premature ovarian failure, you should be knowing that ovarian failure occurring in the age of less than 40-year female. Investigation is FSH more than 40 international units or serum estradiol down to less than 25 picogram. Treatment for premature ovarian failure or ovarian reserve, diminished ovarian reserve, is IVF using donor oocytes. This is like INI, CET, PG entrance level question or important for NEET PG. They have already asked the investigation in AIMS PG entrance. So, I am teaching you a step ahead of your FMGE exam. मतलब अगर कोई difficult pattern questions भी आए, even the PG level, okay, so you should not get stuck up. You should be able to answer if your concepts are very clear. Okay. Now, if I ask you what is the mean age for menopause? What is the mean age for menopause worldwide? Then your answer should be 51 years. In India, it is 47 years. But they ask you worldwide, so your answer is mean age for menopause worldwide is 51 years. Next. Now, if I tell you an ovulation, there are three categories of an ovulation. First is hypogonadotropic hypogonadism, that means FSH and LH are down. So, you have to give the stimulation to the pituitary, this is pituitary failure. Then there can be normogonadotropic anovulation, so diagnosis is PCOD. And if it is hypergonadotropic hypogonadism, that is premature ovarian insufficiency, or like premature ovarian failure. So FSH LH will be elevated in that case. So here I have already discussed the treatment. IVF using donor oocytes. If it is a pituitary failure, okay, problem at the level of pituitary or hypothalamus, there is a GnRH deficiency, you can try giving GnRH pulsatile stimulation. Now PCOD, which is the most common cause for an ovulation, then first step is always lifestyle modification, and second is ovulation induction agents like letrozole or clomiphene citrate, and third is the ovarian drilling. If by chance you are working up a case of infertility and you are doing laparoscopy and you find there is polycystic ovaries, you can do ovarian drilling. Okay, but first answer is always a lifestyle modification. So three causes of anovulation. It can be PCOD where lifestyle modification or ovulation induction agent. It can be hypogonadotropic hypogonadism, so that is pituitary or hypothalamic stimulation has to be done in a pulsatile manner. Third category is premature ovarian failure where IVF using the donor oocytes has to be done. And there is a fourth category, that is it is caused by hyperprolactinemia. Then your drug of choice is bromocriptine. Drug of choice for hyperprolactinemia causing anovulation will not be cabergoline, it will be bromocriptine. So remember, that is a fourth category of anovulation, so it is given a separate category. Next, I come down to the tubal factor of infertility. Tubal factor of infertility, this is an HSG image. So two investigations are done in tubal factor of infertility, HSG followed by laparoscopy. If there is any abnormal findings on HSG, you need to take the patient for laparoscopy. Don't you just jump onto the IVF. Okay, that will be your wrong answer. So always abnormal HSG finding has to be taken up for a laparoscopy. So this is normal HSG, and which is the type of cannula being used. I have taken some of the instruments used in gynae as well in some of the slides to make you prepare. So आपका पूरा preparation चलेगा इसमें, जिसमें कि मैं important topics discuss कर रही हूँ, important points where questions are expected to be asked, images and some of the selected important questions. Okay, so Leash-Wilkinson cannula is being used to put in a dye into the uterus during HSG. Next, laparoscopic chromotubation is the confirmatory investigation where a methylene blue dye is being put into the uterus and the dye enters into the fallopian tube, and you can see the free spill of dye into the peritoneal cavity using a laparoscope. So that is called as laparoscopic chromotubation, which is confirmatory and it is a gold standard investigation. Now, abnormal findings on HSG. You can see bilateral proximal tubal block and you can see bilateral distal tubal block. These images have been asked in FMGE exam. So if there is a bilateral proximal tubal block, the most common cause for this is physiological tubal spasm. So you have to do a hysteroscopic guided tubal cannulation of the fallopian tube, and simultaneously you combine it with laparoscopy because you can do tube testing. You can do tube testing with the methylene blue dye. So, you can cannulate the fallopian tube through hysteroscopic guidance followed by laparoscopic chromotubation. This is a treatment for proximal tubal block. For a distal tubal block, you can go for a tuboplasty using laparoscopy, or if no fruitful results, then you can go for IVF. Now, there is a question and many of the students mark it wrong. This is a question which has been asked in FMGE exam, it has been asked in NEET PG exam, it has been asked in AIMS PG exam, and it has been asked in UPSC exam. A couple came to infertility clinic, semen analysis was done, it is normal. Ovulation studies are done, that is normal. HSG shows bilateral tubal block. What is your next line of management? So, HSG is showing a tubal block. What is your next plan of management? Are you going to do IUI, IVF, laparoscopy or tuboplasty? What's your answer? I have just now discussed what is important. I have just now covered what is important. So, is it IUI, IVF, laparoscopy or tuboplasty? Yes, the correct answer is laparoscopy, because you can check the tubal patency, you can confirm by laparoscopic chromotubation. If the question writes there is a bilateral tubal block on laparoscopy, then what's your management? In that case, you can select your answer as IVF. Next, this is beaded appearance of fallopian tube on HSG. This is genital TB. In this case, your first line of treatment is ATT, and then your best management after the ATT course is over, your best management will be IVF, because tubes are permanently damaged after a genital tuberculosis, and 90% of genital tuberculosis occurs in the fallopian tube, leads to blockage of the fallopian tubes. Next, treatment of bilateral proximal tubal block is hysteroscopic guided tubal cannulation followed by laparoscopy. For the distal tubal block, the best management is IVF. What is the gold standard investigation for tubal and peritoneal factor of infertility? Is always laparoscopy. Laparoscopy has an advantage. If you can see the polycystic, there may be more than one factor of infertility. So, you can do ovarian drilling. If it is endometriosis, you can do adhesiolysis. Okay. If tubal patency you want to check, you can do laparoscopic chromotubation. So, all the very advantages of doing a laparoscopy in infertility patient. Now, next topic of discussion I am taking up is vaginal discharge or vaginitis, which is very important. So, I have covered up ectopic pregnancy and infertility. Now, I am taking up a small topic, that is vaginitis or vaginal discharge. So, this is most of I have written in the single liners form. From these points only the questions are likely to be asked. So, thick curdy white or cottage cheesy discharge, vaginal discharge is seen in, answer is candidiasis. If you are asked, patient is a case of diabetes, she is pregnancy or she is immunocompromised, what type of vaginal discharge is common in that case? So, your answer remains candidiasis. So, thick curdy white vaginal discharge is candidiasis. Next question, greenish creamy color vaginal discharge associated with itching. What's your answer? Answer is trichomoniasis. What is trichomoniasis? Trichomoniasis is caused by a protozoa which is a flagellated microorganism. It is motile microorganism. You can see this on saline microscopy. That is also called as wet film. Saline microscopy also called as wet film, and it is associated with itching. Strawberry spots in vagina is seen in answer trichomoniasis, strawberry spots. Amsel's criteria is seen in answer is bacterial vaginosis. Amsel's criteria is seen in bacterial vaginosis. Yes, I can read your answers. All of you are marking the correct answers. Dr. Randhir, you have marked bacterial vaginosis for which answer? I think Amsel's criteria, yes. What is Amsel's criteria? What is bacterial vaginosis? When normal flora of vagina lactobacillus is been replaced by Gardnerella vaginalis, Mycoplasma or Haemophilus bacteria. So that is term called as bacterial vaginosis. So pH is more than 4.5 alkaline. It is a fishy odor smell, and there are clue cells seen in bacterial vaginosis. This is what is Amsel's criteria. Okay, and you should remember Whiff test is positive in bacterial vaginosis. What is Whiff test? Whiff test is you put KOH on a slide where you have taken the sample. There is a fishy odor smell. There is a fishy odor smell. Fishy odor smell. That is Whiff test. So drug of choice for trichomoniasis and bacterial vaginosis is metronidazole. So drug of choice for trichomoniasis and bacterial vaginosis is metronidazole. Next topic I have taken up is endometriosis. So you can see there is a chocolate cyst of ovary. Chocolate cyst of ovary. Why this is chocolate color? Because of the hemosiderin. So most common site for endometriosis is ovary, and the rare site is CNS. Endometriosis means presence of endometrial glands and stroma outside the uterine cavity. So most common site is the ovary. Most common symptom of endometriosis is always pain. What type of pain? Usually congestive dysmenorrhea. Congestive dysmenorrhea means pain of menstruation starts few days before the onset of periods, continues throughout and then subside. Triad for endometriosis is congestive dysmenorrhea, dyspareunia. Dyspareunia is painful coitus and infertility. Menorrhagia is also a symptom, but that is not counted in the triad. So most important triad for endometriosis is congestive dysmenorrhea, painful coitus, that is dyspareunia, that is presence of endometriosis in the pouch of Douglas causing tenderness and pain during coitus, and there is infertility because fallopian tube is entangled in adhesions. Gold standard investigation for endometriosis always is laparoscopy. It is confirmatory as well as you can do therapeutic management of endometriosis. Now what is the per vaginum finding in endometriosis? In per speculum you can see the puckering spots in the pouch of Douglas, that is endometriotic spots, and in the per vaginum examination uterus is retroverted, normal size, fixed, and there is tenderness in the pouch of Douglas, or there can be bilateral adnexal masses. If it is chocolate cyst ovaries, you might get bilateral adnexal masses in the patient during examination. Okay. Next, triad for endometriosis I have just mentioned. Is it dysmenorrhea, infertility, dyspareunia, menorrhagia, pain, infertility? Menorrhagia, cyclical hematuria, dyspareunia. So the correct answer is dysmenorrhea, infertility and dyspareunia is the classical triad for endometriosis. And you can see there is adhesions. Adhesions in the pouch of Douglas, you can see fallopian tube adhesions, that is peritubal adhesions. Peritubal adhesions, peri-ovarian adhesions, okay, and this is chocolate cyst of ovary. Next, treatment for endometriosis. What are the drugs that treat endometriosis? Is letrozole, danazole and GnRH analogues. This will acting as an anti-estrogen, and endometriosis, there is a pathology that high levels of estrogen is there, which is promoting the growth of the endometriotic tissue, which is ectopic. Okay. Now, drugs that only treat the symptoms of endometriosis. For pain, we use NSAIDs, non-steroidal anti-inflammatory drugs. For menorrhagia, we can use progesterone, we can use OCPs, we can do Mirena insertion, but these drugs do not treat endometriosis. Okay, they are just to treat the symptom of menorrhagia caused by endometriosis. Okay, now surgical management, conservative, or if you are planning adhesiolysis, then best is laparoscopy. If the family complete or there is associated findings of fibroid or adenomyosis, then hysterectomy is reserved for those patients who are not responding to medical treatment but family is complete. Now, next is very important topic, but every time when I have taking up any session, whether it is test and discussion, whether it is high yield question, whether it is guest questions, I usually start with disorders of menstruation. This type I started with other topics which usually get untouched, but it is important for questions. Now, hormone responsible for breast development is estrogen. Hormone responsible for axillary and pubic hair development is androgen. Hence, in cases of androgen insensitivity syndrome, axillary pubic hair are absent. Okay. First sign of puberty in girls is growth spurt, but first visible sign of puberty in girls is hilarchy, that is the breast development. First sign of puberty in boys, increase in testicular size, increase in testicular size. Hormone responsible for puberty changes in boys, testosterone. Hormone responsible for puberty changes in boys is testosterone. So, I hope these questions are very clear to you, because many times on these points the questions are being asked. Now, the hypothalamus, pituitary, ovary and uterus and its outflow tract. Outflow tract means cervix, vagina, hymen. It is been divided into 4 compartments. So, cause of amenorrhea, whether it is primary amenorrhea or whether it is secondary amenorrhea, the cause lies in these compartments. So, we usually try to rule out the causes of uterus and its outflow tract. So, it is given as compartment number 1, ovarian causes compartment number 2, compartment number 3 pituitary causes, compartment number 4 hypothalamic causes. So, hypothalamus usually secretes gonadotropin releasing hormone that acts on the anterior pituitary to cause release of FSH and LH, which acts on the ovary to cause release of estrogen, progesterone and ovulation, that acts on the uterus and its outflow tract to produce periods. So, whenever there is any disorders of menstruation, the cause lies within these compartments. Okay. Now, very important question, and it is been asked as an image based MCQ as well. That is, a patient presented with primary amenorrhea, cyclical pain abdomen every month without visible external bleeding. On examination, there is a bluish membrane bulging, and when you do the examination, breast is present, axillary pubic hair are present. That means ovarian function is normal. Okay, and external genitalia is female. On per rectal examination with a consent, you can check uterus is present. So what is this clinical scenario diagnosis according to you? I can read your answer. This is imperforate hymen, or can be written as congenital cryptomenoria, or can be written as hematocolpos. So, hypothalamus, pituitary, ovary, uterus, whole axis is normal. Endometrial lining is been formed, but endometrial shedding is occurring, but there is no visible bleeding. So, this menstrual blood keep on collecting in the vagina, that is called as hematocolpos. So, what is the treatment for imperforate hymen? Is cruciate incision and drainage. Cruciate incision and drainage. Fine. Next, this is an image based question. An image of a patient is given, and in the question it is written, a 14-year-old girl presented with primary amenorrhea, and you can see this image and karyotype. What is your diagnosis? What do you see in this image? You can see there is congenital webbing of neck. You don't see any breast development. There is no breast development. Short stature you cannot judge from image, so please do not comment. Then there is cubitus valgus deformity. So what is this? And what is this karyotype showing? One X is absent. So karyotype is 45XO, and diagnosis is Turner syndrome. Now what type of amenorrhea it causes? It causes primary amenorrhea. So this is the most common cause for primary amenorrhea, that is ovarian dysgenesis. Ovarian dysgenesis, and there is streak gonads and non-functioning ovaries on ultrasound. Okay, so a short stature female, congenital webbing of neck, no breast development, primary amenorrhea, cubitus valgus deformity, karyotype 45XO, and on ultrasound there is streak gonads and uterus is present, but it is hypoplastic, and genitalia is female, which is infantile. So what is the type of congenital heart disease seen in Turner syndrome? Is bicuspid aortic valve, bicuspid aortic valve, or coarctation of aorta, bicuspid aortic valve or coarctation of aorta. Next, if a female presented with primary amenorrhea, it can be Mullerian agenesis, it can be androgen insensitivity syndrome, or it can be Turner syndrome. So let us see what are the findings. In Mullerian agenesis, so first of all the patient has presented with primary amenorrhea. Now I am taking the consent and doing the general physical examination. Breast development is present in Mullerian agenesis, axillary pubic hair will be present, uterus will be absent on per rectal examination, and on ultrasound the gonad seen is ovary, and karyotype, if you get it done, is 46XX. Now in cases of androgen insensitivity syndrome, breast development is present, but axillary pubic hair are absent, and external genitalia is female, and there is bilateral inguinal hernia. There is bilateral inguinal hernia. On ultrasound, it is undescended testis. On per rectal examination, uterus is absent. Karyotype in this case is 46XY. So this is a case of male pseudo hermaphrodite. Male pseudo hermaphrodite. Turner syndrome, there is no breast development, axillary pubic hair are again not developed, and there is uterus present on per rectal examination. On ultrasound, there are streak gonads and karyotype is 45XO. Now, what is the treatment you can offer if Mullerian agenesis patient is about to get married? Vaginoplasty can be offered. In cases of androgen insensitivity syndrome, there is a risk for testicular tumors, so we will offer gonadectomy. In Turner syndrome, you will give estrogen therapy, like to treat the osteoporosis. And these patients of Turner syndrome are at risk of diabetes, diabetes, autoimmune, thyroiditis later in life, and they are at risk of ovarian tumor, that is gonadoblastoma. So with this one, this is what is a crisp, concise, rapid fire revision, where from one slide you are revising the 3 syndromes. Primary amenorrhea, you will check the breast development, axillary pubic hair development, inguinal region for any inguinal hernia, genitalia, whether it is female genitalia or male genitalia, per rectal examination, uterus is present or absent. Then first investigation you will offer in this patient is ultrasound. Karyotype is not your first investigation. So with this you are able to revise the 3 syndromes plus cryptomenorrhea. All of the following are the causes of primary amenorrhea except. What is your answer? Turner syndrome, Sheehan syndrome, Mullerian agenesis, or androgen insensitivity syndrome? What's your answer? You can write down your answers in the chat box. Yes, I am going to cover up almost all of the topics. एक दो topics अगर रह भी जाते हैं, you can go through, because I have already discussed in the MCQs form in MCQs for FMGE exam, guess questions for FMGE exam, and 5 years PYQs. Yes, Sheehan syndrome is postpartum pituitary necrosis that is the cause of secondary amenorrhea. One important thing I would like to mention, if there is a female, she presented with secondary amenorrhea, there is a history of DNC done 4 months back and FSH levels are 7 international units. What's your diagnosis? Such a question has been asked. Secondary amenorrhea after a DNC and FSH levels are given. What's your answer? What's your diagnosis in this question? This is a very, very important question. It was a question of AIMS PG, but it has been asked in FMG exam as well. What's your answer? After a DNC, there is secondary amenorrhea. So this is, friends, Escherman syndrome, which is formation of synechiae occurring after a DNC. So Escherman syndrome, you can get HSG done, and the gold standard will be hysteroscopy, because you can treat it. Yes. Next, 18-year-old girl presented with primary amenorrhea, breast development is normal, axillary pubic hair are absent, bilateral inguinal hernia, ultrasound shows absent uterus. What is your diagnosis? Androgen insensitivity, Turner syndrome, Mullerian agenesis, or polycystic ovarian disease? There is bilateral inguinal hernia, absent axillary pubic hair, and breast development is normal. What is your diagnosis? Come on. Again, this was an AIMS PG question and it has been asked in FMG exam as well. So what's your answer? Yes. What's your answer? Yes, this is androgen insensitivity syndrome because axillary pubic hair are absent. Next, 19-year-old girl presented with primary amenorrhea, axillary pubic hair are normal, ultrasound shows absent uterus. What's your diagnosis? Androgen insensitivity syndrome, Mullerian agenesis, Turner syndrome or Swyer syndrome. So we are doing a quick and crisp revision of whole of the syllabus. So what's your answer in this question? What's your answer? Axillary pubic hair present, absent uterus, primary amenorrhea. This is no other than Mullerian agenesis. Okay, because breast development is normal, that means ovarian function is normal and karyotype will be 46XX in this case. Next, polycystic ovarian disease, that is again very important. Most of the time they ask you a question. A young female presented with hirsutism and menstrual disturbance like oligomenorrhea, secondary amenorrhea. What's your diagnosis? Is PCOD, and the differential diagnosis is congenital adrenal hyperplasia, late onset. Congenital adrenal hyperplasia, late onset. Okay. Now, in cases of congenital adrenal hyperplasia, they will give you a history of prepubertal hirsutism. Prepubertal hirsutism. If it is rapid onset of hirsutism, then your answer can be androgen secreting ovarian tumors. Androgen secreting ovarian tumors. Okay. If there is a history of clitoromegaly and virilization occurring plus secondary amenorrhea, clitoromegaly, virilization and secondary amenorrhea, then that is virilizing ovarian tumor. So in this one slide I have told you 4 questions. Hirsutism, menstrual disturbance, young patient, provided other causes of hirsutism ruled out, your answer is PCOD. Close differential diagnosis is congenital adrenal hyperplasia, late onset. Then your answer in the hint, the question in the hint will be prepubertal hirsutism. Third question, rapid onset of hirsutism, then androgen secreting ovarian tumor. If it is a female like 40-year, clitoromegaly, virilization, secondary amenorrhea, voice changes, then that is virilizing ovarian tumors. Okay. Next, in PCOS you have to remember the Rotterdam criteria like hyperandrogenism, clinically hirsutism, acne, alopecia, ovarian dysfunction leading to oligomenorrhea or secondary amenorrhea, and ultrasound showing polycystic ovarian disease. This is Rotterdam criteria for polycystic ovarian disease. Rotterdam criteria for polycystic ovarian disease. Now, this is hirsutism. It can be an image based question that can be asked. There is acne, another presentation of hyperandrogenism. So, first line management for PCOS obese patients. What's your answer? What is your first line management? A female presented with hirsutism and menstrual disturbance and it is PCOS, and there is, like, what is your first line management if it is obese patient? Your answer will be lifestyle modification. Your answer will be lifestyle modification. Lifestyle modification. Okay. What's your second line management in PCOS patient? Is drugs. So, menstrual disturbance plus hirsutism, what is the preferred drug? Is OCPs. Now, in the OCPs, there is third generation progesterone or there is fourth generation progesterone that is preferred because they decrease the free testosterone levels by increasing sex hormone binding globulin. So, there is no free testosterone available to cause hirsutism. Okay. Drug to treat secondary amenorrhea is progesterone. Drug to treat infertility is ovulation induction agents. Drug to treat infertility is ovulation induction agents. Okay, so remember. Next, a 28-year-old obese female, she has hirsutis, oligomenorrhea, and her investigation shows PCOS. What's your first line management? This is a question from NEET PG. What's your answer for this? What is your answer? Yes, Dr. Shekhar, you are correct. Dr. Rupinder, you are correct. This is lifestyle modification. Although all of the four are applicable in this case, but most appropriate answer is lifestyle modification first. Now, next topic of discussion. Next topic of discussion is contraception. So, this is Mala N. This is a government supply OCP. And this is IUCD. Which IUCD? Copper T 380A. Again, that is government supply and we are applying free of cost. Okay. So, Mala N. What is the composition? Composition is 30 micrograms of ethinyl estradiol plus 0.15 milligrams of levonorgestrel. Okay. And when do you start a pack of OCP? Is from first day of cycle if she wants contraception in that first month of starting the OCPs. Then she should start on day 1 of the menstrual cycle. Which is the type of iron being added in Mala N tablet? It is ferrous fumarate. Ferrous fumarate. And how many number of tablets are there? 28 days, 21 hormone and 7 iron. Okay. Next, copper T 380A is a longest acting IUCD. Its effective period is 10 years and failure rate is 0.6 per 100 women year. How do you check the failure rate? Failure rate, you check it by Pearl index. Pearl index is used to calculate the accidental pregnancies or contraceptive failure. Okay. Accidental pregnancies or contraceptive failure. Next, OCPs, what is the mechanism of action? Suppression of ovulation, cervical mucus changes or endometrial changes? The correct answer will be all of the above. But if all of the above option is not written, then the best answer you will mark is suppression of ovulation. Failure rate of OCP is 0.1 per 100 women years. Then you should always revise the absolute and relative contraindications of OCPs, benefits of OCPs, because that is very, very important. Next, choice of contraception. This is more of the single liners and it is very important not for FMGE exam but also for the NEET PG, INI CET, FMG as well as UPSC all exams. Choice of contraception in a newlywed female is OCPs. Choice of contraception in a female with menstrual disturbance is OCPs. Choice of contraception in a female with trophoblastic tumor, treatment has been given, now she is on follow-up, is OCPs, because a patient of choriocarcinoma, if undergone treatment and she is on follow-up for 2 years, okay, then what is a tumor marker for choriocarcinoma? Beta HCG. And what is a hormone secreted in pregnancy is beta HCG. So, how will you be able to differentiate that this beta HCG which is detectable in the blood is because of a pregnancy or is it because of recurrence of the trophoblastic tumor? Hence, your patient should not conceive during the follow-up period. So, best contraception in that case will be OCPs. Next, choice of contraception in case of promiscuity. Promiscuity means multiple sexual partners. If there is history of STD, PID or cancer cervix, then the choice of contraception is condoms. That is a barrier contraceptive. Spacing contraceptive is always IUCD. Spacing contraceptive is always IUCD. Otherwise, you can offer the injectable contraceptive, subdermal implants, they are also applicable, but the best one we say is IUCD. Now, choice of contraception in a lactating female is mini pill, but other contraceptive methods are also applicable. Only OCPs have to be avoided for 6 weeks because estrogen suppresses the breast milk. Choice of contraception in sickle cell anemia is DMPA injection. DMPA injection. Now, OCP increase the risk of which of the following cancer? Ovarian cancer, adenocarcinoma cervix, benign breast disease or ovarian cyst. Benign breast disease or ovarian cyst, it gives protection. Ovarian cancer, it gives protection. So, it increases the risk of adenocarcinoma cervix. OCPs are known to increase the risk of adenocarcinoma cervix. Now, OCP gives protection against benign breast diseases from ovarian cyst, ovarian cancers. Which type of ovarian cancers? Only epithelial ovarian tumors. It do not provide any protection against germ cell tumors or sex cord tumors. Then it gives protection against endometrial cancer. It gives protection against colorectal cancer. It gives protection against choriocarcinoma. So, OCP gives protection against benign breast diseases, ovarian cyst, ovarian cancer, endometrial cancer, colorectal cancer and choriocarcinoma. Okay. Next. Now, identify the type of contraceptive. This is copper T 380A government supply. This is multi-load. This is hormone releasing IUCD Mirena, which contains 52 milligrams of levonorgestrel and it releases 20 micrograms per day. Failure rate is 0.1 per 100 women years. 0.1 per 100 women years. And Mirena has got additional advantage. It can be applied in the patients who are having menorrhagia, but provided the causes of menorrhagia is ruled out. So, you can apply in the patients of premenstrual syndrome, in patients of abnormal uterine bleeding, but cause is hormonal imbalance, you can apply in patients of endometriosis, in patients of adenomyosis. So, these are the advantages of Mirena, because Mirena reduces the menstrual blood loss up to 97% cases. So, it is a preferred contraceptive in menstrual disturbance patients where like OCPs are contraindicated, you can offer Mirena. Now, 30-year-old female was using copper T. Now, she comes with 8 weeks amenorrhea, copper T in situ and thread is visible. What's your next line of management? This is very important question of FMG. It has been asked in other exams as well. Okay. So, what's your answer? Remove copper T and give her a choice of MTP. Remove copper T as it is teratogenic. Ask her to continue pregnancy. Remove copper T after delivery. What's your answer? Patient has come up with amenorrhea 8 weeks and she was using copper T and she is conceived. But on doing the pars speculum examination, copper T thread is visible. So, what's your management in this case? So, management is remove copper T and give her a choice of MTP. If the thread is not visible, if copper T thread is not visible, then your answer is continue pregnancy and remove copper T after delivery. Okay. Next, this is Antra. This is National Family Planning method of contraception, which is free, in the government supply. Okay, mechanism of action is inhibiting ovulation. Dose is 150 milligram 3 monthly injection. This is DMPA injection, depot medroxyprogesterone acetate, or it can be given 300 milligram 6 monthly injection. This is a choice of contraception in sickle cell anemia patient, and it is also preferred in epilepsy patient. Okay. Now failure rate of DMPA injection is 0.3 per 100 women years. 0.3 per 100 women years. Important side effect of this injection is it causes irregular vaginal bleeding, and long run it is not preferred in young females because it decreases bone mineral density. So if a female is using and she is young, for a longer duration she is using, then there may be a chance of osteoporosis. Next, what are LARC contraceptives? LARC means long acting reversible contraceptive. So what are LARC contraceptives? Is DMPA injection, IUCD, and subdermal implants. These are reversible, long acting reversible contraceptives. Okay, what is this image showing? This image is showing Implanon. That is a single rod. It contains 68 milligram of etonorgestrel, and mechanism of action is suppression of ovulation. Advantage is it do not decrease bone mineral density, but side effect is irregular bleeding. Side effect is irregular bleeding. Okay. Implanon. Chaya. Chaya is non-steroidal contraceptive pill. Okay. It is to be given twice a week for 3 months, followed by once a week. Okay. So what we were using, Saheli, this is Chaya. This is again a government supply contraceptive pill, but it is non-steroidal contraceptive pill. Okay, agreed. So ये जो contraceptive है government supply में है, this is non-steroidal contraceptive pill. Twice a week इसको use करना होता है for 3 months and then followed by once a week pill. Now is it okay? Fine. Next, post-coital contraception या emergency contraception. Who are the likely candidates? Those who have unprotected coitus, those who are rape victims. So post-coital और emergency contraception देते हैं. Post-coital और emergency contraception दो type का है. There is hormonal, to be given within 72 hours of unprotected coitus, or it is IUCD, to be given within 5 days of unprotected coitus. IUCD में आता है copper T and hormonal में आता है LNG pill, which is 1.5 milligram single dose. Number 2 OCPs, number 3 RU 486, and ulipristal भी है, but ulipristal is not available in India. That is selective progesterone receptor modulator. Dose is 30 milligram, to be given within 5 days of unprotected coitus. Which is most commonly used emergency contraception in India? Then it is always LNG pill. Okay, LNG pill. Number 2, the best post-coital contraception, answer is copper T, that is a type of IUCD. Which is not an emergency contraception? Mirena is not an emergency contraception. Misoprostol भी emergency contraception नहीं है. Okay, Misoprostol is not emergency contraception. Fine. Next. This is diaphragm, female barrier contraceptive. This is Today. Today is a vaginal sponge which releases a spermicidal agent, nanoxynol 9. This is Fem Shield, that is female condom. ठीक है, तो कभी कभी इमेज बेस्ड क्वेश्चंस भी आ जाते हैं जिसमें कि इन्होंने टुडे पूछा है और फेमशील्ड पूछा है और पूछा है स्पर्मिसाइडल एजेंट रिलीज्ड बाय टुडे. सो आंसर इज नेनॉक्सिनॉल 9. नेक्स्ट, a 32-year-old female came 4 days after unprotected coitus asking for your contraceptive advice. What is your answer? क्या दोगे उसको? She has come 4 days after unprotected coitus. LNG pill, copper tea, OCPs या laparoscopic tubectomy. She has come 4 days after unprotected coitus asking for a contraceptive advice. What will you give? What's your answer? What are you going to mark in this question? Yes, all of you are correct. This is copper tea because she has come 4 days after unprotected coitus. Next, name the tubal ligation method shown in this image. कौन सा tubal ligation method है ये? This is modified Pomeroy's technique of tubal ligation. Which part of the fallopian tube is cut? Isthmic part. What is the failure rate? 0.1 to 0.4%. Okay. Next, what is this instrument shown in this image? This is laprocator which has got prongs for laparoscopic sterilization. What is the intra-abdominal pressure in laparoscopic sterilization? 10 to 20 millimeters of mercury. Which material is applied on the fallopian tube? Answer is fallope rings, that is silastic rings. Fallope rings, that is silastic rings. Okay. What is the failure rate of this method? 0.6%. Which is a gas used to create a pneumoperitoneum? Answer carbon dioxide. Next, identify the method of sterilization. What is shown in this? Laparoscopic sterilization, hysteroscopic sterilization or mini lap? Laparoscopic sterilization, hysteroscopic sterilization or mini lap? What's your answer? This is Assure. This is hysteroscopic sterilization. A metallic coil has been put into the fallopian tube through hysteroscopy. There is epithelialization which takes place in 3 months time. So additional backup method should be used after this particular type of sterilization method. Next, backup method required after vasectomy is for 3 months. What is the failure rate of vasectomy? 0.15 per 100 women year. Okay. So this is about the contraception methods. Now some of the instruments used in gynae. Some selective images I have taken it. You are supposed to identify. This they have already asked in FMGE exam. This is Babcock's forceps used for holding the tubular structures like fallopian tube during tubal ligation. Okay. This is ovum forceps. This is used to perform dilatation and evacuation in cases of MTP, in cases of incomplete or inevitable abortion. This is Ellis tissue forceps to hold the tough structures like rectus sheath. This is Veery's needle. Veery's needle. Next, this is uterine sound. This is curate. Okay. Next, this is Doyne's retractor. This we use in the surgeries, like we want to retract the urinary bladder during cesarean section or during hysterectomy. This is episiotomy scissors. Episiotomy scissors. This is Cocker's artery forceps. This is Leash Wilkinson cannula. This is used during HSG. Cocker's artery forceps can be used as a clamp in gynae surgeries. It can be used in obstetric to perform artificial rupture of membranes. Artificial rupture of membranes. So friends, just revise these instruments. This is important. Some of them has already been asked in your exams, like Leash Wilkinson cannula they have asked, Babcock's forceps they have asked, ovum forceps they have asked, Veery's needle they have asked, curette they have asked, episiotomy scissors has been asked in AIMS PG. Then they have asked Leash Wilkinson cannula in FMG exam. So some of the selective instruments I have pasted in this slide. Next important topic is fibroid. So I am almost finishing the gynae revision. This is very helpful for you, because all those points where the previous 5 years questions in FMG has been asked, and even in the PG entrance, I have selected all that, okay, in these slides. So do revise this content. It is really going to be helpful for your preparation. And OBS Gynae is a very scoring subject. 10 to 15% of your FMG exam paper is OBS and Gynae. OBS and Gynae is again important for UPSC exam, which you are going to write. The form will be released in April and the exam will be in July, most probably July. And you know, I hope sincerely that all of you get through your FMG exam. Then you are feel free to write your UPSC exam, which is a combined medical officer exam. Okay, I have already posted a video in the NExT YouTube channel. You can go through. Now fibroid, most common presentation of fibroid. Mostly the fibroids are asymptomatic. It is an incidental finding. Okay, most common symptom of fibroid is menstrual symptoms like menorrhagia. Which type of fibroid causes menorrhagia? Submucosal and then intramural. In case of irregular vaginal bleeding or intermenstrual bleeding, it is almost likely that it is submucosal fibroid. What is the rarest change occurring in fibroid? Is sarcomatous change, like sudden increase in the size of the fibroid, then worsening of menstrual symptoms. You can suspect a sarcomatous change, that is 0.5%. If your concepts are very clear, I would say you should get 30 out of 30. Okay, provided that throughout the time you have done your preparation well, and this is how you grasp the subject. That is very important. If you are thinking this is the first time you are revising the subject, then I am sorry to say, then I cannot tell you that you can get 30 out of 30. But if you have already been thorough with the subject, most of the content you already have and you have gone through, this is your final revision, which is like rapid fire revision. Okay. Next, if you get a question, a patient is having intermenstrual bleeding or in between the cycles, that is metrorrhagia, and you get an image like this. This is endometrial polyp. And what is a hint in this question? The hint will be given as feeder vessel sign on Doppler. Feeder vessel sign on Doppler. Then what will be your management? Management will be hysteroscopic guided removal, followed by histopathological examination. So gold standard for this kind of a question, intermenstrual bleeding and feeder vessel sign on Doppler. What is it? The diagnosis is endometrial polyp and the gold standard investigation will be hysteroscopic guided removal and followed by histopathological examination. Now ulipristal, what is it? Is it selective progesterone receptor modulator, selective estrogen receptor modulator, aromatase inhibitor, GnRH agonist? This is selective progesterone receptor modulator and there are two uses of ulipristal. It is used as a postcoital contraception and it is used in fibroid uterus. It causes shrinkage in the size of the uterus, fibroid. Next, all of the following are true about red degeneration of fibroid, except red degeneration of fibroid occurs in the second half of pregnancy. A lady is pregnant and she is having fibroid. She presented with acute pain abdomen. My first diagnosis in that case will be abruptio placentae. But if there is a history of fibroid, I can think of the red degeneration of the fibroid and investigation will be ultrasound. Now what is the wrong answer in this case? It occurs in pregnancy, true. The cause is aseptic infarction, true. Admission is required, yes. Surgical intervention is to be done, wrong. The management is always conservative. That is admit, IV fluids, analgesics, okay, and she will be fine. Okay. Next, menorrhagia is a main symptom of which type of fibroid? Menorrhagia is a main symptom of submucosal fibroid. For submucosal fibroid, the best or gold standard investigation will be hysteroscopy because you can do the fibroid removal. Okay. Next, what are the drugs that decrease the size of fibroid? Is GnRH analogues, that is agonist, antagonist, letrozole, danazole, RU486 and ulipristal. Mind it, OCPs, progesterone, Mirena are given to treat the symptoms of menorrhagia, but they do not shrink the size of the fibroid. OCPs, progesterone, Mirena are given to treat the symptom of menorrhagia. They do not shrink the size of the fibroid. Next, cancers in gynae. Cancers in gynae. This is again a very important topic. Most common cancer in female in world is a breast cancer. Most common cancer in female in India is again breast cancer. Most common cancer in female in genital tract in India is cancer cervix. Every 8 minutes, one death in India in a female occurs from cancer cervix. So daily 200 deaths are occurring. So that's a huge number. Most common cause of cancer cervix, human papilloma virus 1618, that is a proven cause. HPV 1618 causes genital warts and condyloma acuminata. They have asked image based question in this. Okay. Next, cancer cervix. Cancer cervix, what are the screening methods? Remember, I am teaching you very latest because I am already working in a reputed cancer hospital of Delhi. So, pap smear, HPV DNA testing, visual inspection under acetic acid and villi, these are all screening methods. Remember, colposcopy is a confirmatory test. It is never a screening method. Cost effective screening method for cancer cervix or dysplasia cervix is VIA, that is visual inspection under acetic acid in low resource countries. Best screening method nowadays is HPV DNA testing. We take a sample, like we take up a pap smear, that is a liquid based cytology, and we send it for HPV DNA testing. HPV DNA testing is not a blood test, it is a sample taken from cervix, like we take up a pap smear, okay, and we send it to our genetics lab. Age to start HPV DNA is 30 years of age. Remember, this is a very, very important content and confirmatory answers I am telling you. Next, which viral protein? HPV is a DNA virus, it causes infection in the epithelial cells of the cervix. It incorporates its DNA and it uses the host machinery to replicate, to cause malignant transformation. Okay, so which viral proteins causes viral replication? E1, E2, and E6, E7 causes malignant transformation, and L1 protein is the one from where the HPV vaccine is being derived. So this is an INI CET PG entrance question. Which viral protein you derive the vaccine? Answer is L1 protein, and E1, E2 is for viral replication, E6 and E7 is for malignant transformation. This discussion is again important for PG entrance as well. Next, HPV subtypes are low risk and high risk. Low risk is HPV 611, which causes genital warts and condyloma. HPV 16, 18, 31, 33, 45, 52, 58 are having high oncogenic potential, and it is a risk factor for cancer cervix, vulva and vagina in the female, oropharyngeal, penile and anorectal cancer in males. That is why there is an important concept of vaccination. Vaccinate the children between 9 to 26 years of age or before the sexual activity starts. Ideal age group according to WHO is 11 to 12 years. There is a global eradication strategy of cancer cervix, that is 90% girls should vaccinate, 70% of the females should be screened, and 90% should get the treatment for cancer cervix to eradicate the cancer cervix. Okay, 90, 70, 90 strategy. Next, pap smear is a screening test and we use the Ayers spatula for taking a sample, and this is a cyto brush. We take the sample from the lip of the cervix and cervical canal and we make 2 slides, fix it and send it for examination. Then there is also a liquid based cytology where this spatula is being used to collect the pap smear. Okay. Now pap smear age group is, we start 21 years of age in a sexually active female. Sexually active female. We repeat it every 3 yearly till her age is 30 years, then every 5 yearly along with HPV DNA testing till 60 to 65 and then stop. If the facility for HPV DNA is not available, then we can do pap smear every 3 yearly after 30 years. Next, this is colposcopy. This is a confirmatory test to take a colposcopic directed cervical biopsy in cases of abnormal pap smear findings. Okay. Next, we visualize the cervix on colposcopy. We apply 3 to 5% acetic acid and visualize, and we can take a biopsy from aceto-white areas. The important question asked was which is used in colposcopy? Answer acetic acid. And which is the filter we use it? We switch to green filter to visualize the abnormal vessels. This is FMGE exam question. Which color filter is used? Green color filter. fixator used in pap smear is 95% ethanol plus ether. And if you are taking a liquid based cytology, then this contains methanol as a fixator. Okay. Next, this is LEAP instrument. LEAP is a best treatment for CIN2 and CIN3 in young females where you don't want to do hysterectomy. LEAP means loop electrosurgical excision procedure. Okay, LEAP is loop electrosurgical excision procedure. This is the best treatment in modern times for CIN2 and CIN3. A low voltage electric current is passed and this loop is to cause a cautery effect or it causes excision effect. Cautery or excision effect. Next, a 35-year-old female P2L2 CIN3 on colposcopic directed cervical biopsy. What's your next step in management? Since the age of the patient is young, I am going to do LEAP. Although all of the four are applicable in this case, but the best answer is LEAP. Next, all of the following are screening methods for CIN3 except colposcopy. Which is the best screening method? HPV DNA. Which is the most commonly done screening method? But after pap smear finding, you need to do the colposcopy. Okay, so specialized training and setup is needed for colposcopy. If you are asked cost effective method in the low resource countries or where mass screening is needed, then your answer is VIA. VIA. Okay. Next, vaccination. Vaccination, there is Gardasil. Gardasil, that is a quadrivalent vaccine, HPV 6, 11, 16, 18. Okay. And there is Gardasil 9, that is a nonavalent vaccine. This is quadrivalent. Nonavalent means HPV 6, 11, 16, 18, 31, 33, 45, 52, 58. Cost of one dose of Gardasil is nearly 10,000. Okay. Cost of quadrivalent vaccine, one dose is 3,500. Okay. So there are additional strains, so additional benefits. We should be vaccinating the boys and as well as the girls. Next, symptoms of cancer cervix. Most common symptom is any irregular vaginal bleeding. You should always rule out cancer cervix. Most specific is post-coital bleeding. Post-coital bleeding. Obvious growth on cervix. Next step in management is cervical punch biopsy. Cervical punch biopsy. Next, radiosensitizer drug in cancer cervix is cisplatin. Treatment of CIN2 and CIN3 is LEAP. Discrepancy between cytology, colposcopy and cervical biopsy. Next management will be conization or cone biopsy. Now, stage-wise treatment. Stage 1A1, 1A2, 1B1, B2 and 2A. We go for a surgery. 1B3 and A2. And stage 2B3 and 4, we go for concurrent chemoradiation. Recently asked question in FMGE exam. So, for how many total doses of the vaccine? Vaccine doses is 0, 2 and 6 months. But there are latest SAGE guidelines. They say 1 or 2 doses is enough. in less than 14 years of age and 2 to 3 doses between 14 to 26 years of age. FDA says that we can give this vaccine. WHO says 9 to 26 years or before sexual activity. FDA says 9 to 45 years of age. So 1 to 2 dosage in less than 14, 2 to 3 doses in 14 to 26 years of age. Next, 55-year-old female was found to have cancer cervix FIGO stage 2-3, locally advanced. What is your management? You're going to tell me this answer. Surgery plus chemotherapy, chemotherapy, radiotherapy plus chemotherapy, radiotherapy and HPV vaccine. What's your best answer? What will you mark? This is an AIMS PG question, but a similar question has been asked in FMGE exam as well. What's your answer? So this is radiotherapy plus chemotherapy. Radiotherapy plus chemotherapy, or we can call it as concurrent chemo radiation. Concurrent chemo radiation. Next, endometrial cancer. Risk factors you should know, like polycystic ovarian disease, hormonal replacement therapy, endometrial hyperplasia, nulliparity, infertility, then early menarche, late menopause, obesity, diabetes, hypertension, tamoxifen, feminizing ovarian tumor like granulosa cell tumor, etc. So you should remember the risk factor. What is the cutoff value for endometrial thickness in a menopausal lady? Endometrial thickness, you check it on transvaginal scan. It should be less than 4 mm. Important presentation of cancer endometrium is irregular vaginal bleeding, but most specific case post-menopausal bleeding. Okay, most specific case post-menopausal bleeding. Students, we just give our content to the academy. Okay, so soft copy is with the academy, and if they want they can provide the PDF, they will provide the link. Okay. Postmenopausal bleeding, first investigation to be done is transvaginal scan, and you check the endometrial thickness. If it is less than 4 mm, just a follow up is needed. If it is more than 4 mm, you can go for endometrial sampling using a pipette or Carman's cannula. You can use a pipette or Carman's cannula. Or if it is showing a focal thickness or a space occupying lesion, then you should go for hysteroscopic guided biopsy. Okay, otherwise you go for endometrial sampling followed by histopath to rule out endometrial hyperplasia or endometrial cancer. So if a female presented with postmenopausal bleeding, first step is always transvaginal scan. Nowadays on postmenopausal bleeding or abnormal uterine bleeding, there are many questions being asked in FMGE exam as well. Okay, so first step is transvaginal scan and you check endometrial thickness. If it is less than 4 mm, just do the follow up. If it is more than 4 mm, do endometrial sampling using pipette or Carman's cannula. For histopathology, you send the sample. For endometrial hyperplasia or endometrial cancer, if it is showing focal thickness or space occupying lesion, then you go for a hysteroscopy. Now for more than 4 mm endometrial thickness, you go for endometrial sampling is being done, okay, to rule out endometrial cancer. If there is a focal thickness, then you go for hysteroscopy. Okay, this is pupil. Now, most common type of endometrial cancer is endometrioid adenocarcinoma. 80% of endometrial cancer is arising from glands. Poor prognosis is for clear cell carcinoma or papillary serous carcinoma. Treatment options are: for stage 1, you do surgery. If unfit, you go for radiotherapy. So, if it is grade 1 and 2, stage 1A and 1B, you go for surgery. If lymph nodes are negative, you just do the follow-up. In cases of stage 1, grade 3, you go for surgery followed by radiotherapy. In stage 2, you go for surgery plus post-operative radiotherapy. Okay. In stage 3 and 4, you go for debulking surgery, radiotherapy, chemotherapy and palliative treatment. Okay, and palliative treatment. Next, ovarian tumors. Mostly ovarian tumors are epithelial in origin, then germ cell tumors, then sex cord tumors, and number 4 is metastatic tumors, which is Krukenberg. Okay. Now, dysgerminoma, what are the tumor markers? Dysgerminoma tumor markers are LDH and alkaline phosphatase. Yolk sac tumor, the tumor markers are alpha fetoprotein and antitrypsin. For choriocarcinoma, it is beta HCG. For granulosa cell tumor, it is inhibin. Okay. So, remember tumor markers in cases of ovarian cancers. Next, serous tumors, what is the histopathological findings? It is psammoma bodies. Yolk sac tumor, it is Schiller duval bodies. Granulosa cell tumor, it is Kohl-Exner bodies. Krukenberg, it is signet ring cell. So, remember this. This is very, very important. Okay. Yes, I can read your answers. I know while you are attending the session and you don't have a soft copy and you are just listening, some of you are writing, but this is just a revision because you have already read in the lectures. This is a final revision which is going on. Okay. So, histopathological slides. This is psammoma bodies seen in serous tumors. This is Schiller duval bodies seen in yolk sac tumor. This is Kohl-Exner bodies seen in granulosa cell tumor. This is signet ring cell seen in Krukenberg's tumor. Now, a patient presenting with adnexal mass was operated and it is removed. What do you see? You see this is mature teratoma because you can see the teeth, you can see the hair, you can see the sebaceous material. So, this is an image of dermoid cyst. Okay, image of a dermoid cyst. Most common germ cell tumor of the ovary is dermoid cyst. Most common clinically detected ovarian tumor is dermoid cyst. Most common ovarian tumor to undergo torsion is dermoid cyst. Most common pure malignant germ cell tumor dysgerminoma, most common epithelial ovarian tumor, serous, cyst, adenoma, most rapidly growing ovarian tumor, yolk sac tumor, largest ovarian tumor, mucinous, cyst, adenoma, ovarian tumor metastasizing to contralateral ovary, granulosa cell tumor. So remember this, this is very, very important. Thank you so much. So this is very, very important. Please do revise this way. Next, I am taking up now the second part of this, that is obstetric revision. So most of the content of gynecology I have made you revise. Okay. Now just remember, there can be a question from the urinary fistulae, there can be a question from genital prolapse, but they are very, very selective questions. You can read from the notes that you have attended the classes. Okay. Now, first of all, I am taking up preeclampsia, which is very important for your exam point of view. Gestational hypertension, preeclampsia, eclampsia, chronic hypertension, and superimposed upon preeclamptic changes. In gestational hypertension, it is developing after 20 weeks of pregnancy. There is blood pressure more than or equal to 140/90, and there is no proteinuria. PP comes down to normal within 3 months. That is gestational hypertension, question being asked in FMGE exam. Number 2, preeclampsia means blood pressure plus proteinuria developing after 20 weeks. Proteinuria, although does not signify the severity. Okay. Eclampsia means convulsions occurring, it is GTCS convulsions. Chronic hypertension is blood pressure present in less than 20 weeks of pregnancy and there is no proteinuria, and BP will not come down to normal even after delivery. Chronic hypertension means there is chronic hypertension superimposed by preeclamptic changes, means there is hypertension in the beginning of pregnancy and now proteinuria is added, or an organ damage, or persistently raised blood pressure which is uncontrolled. Okay. Next, a pregnant lady with 36 weeks of pregnancy came with blurring of vision, headache, blood pressure is 180/120. After repeating, it is still high. So this is a case of severe preeclampsia. What is your next line of management? Admit and observe. Admit antihypertensive, continue the pregnancy till term. Admit antihypertensive. Tenor staging is, like 5 stages for breast development and 5 stages for axillary pubic hair development. Details of tenor staging is not been asked in FMG exam. Then what is your correct answer for this question? It is admit antihypertensive, continue the pregnancy. If you mark, this is wrong. Okay. Many of you are likely to mark this, that is a wrong answer. Correct answer is admit, give antihypertensive, magnesium sulfate and terminate, because first line of management in severe preeclampsia with warning symptoms is start anticonvulsant to prevent convulsant, and anticonvulsant of choice is magnesium sulfate, followed by definite management. Definite management is termination of pregnancy. I am not saying that you should straight away take the patient for cesarean. Do a per vaginum examination, assess the Bishop score and then decide the mode of delivery. Next, all of the following are risk factors for preeclampsia except twin pregnancy, primigravida, multiparity or antiphospholipid antibody syndrome. So multiparity is a wrong answer because PIH or pregnancy induced hypertension is more common in primigravida. Antihypertensive preferred in pregnancy is labetalol, which is alpha plus beta blocker. Its onset of action is fast, it is very safe, no teratogenic effect, and it can be given oral or IV. Okay, so that is why labetalol is preferred. What are the other preferred drugs? Hydralazine, nifedipine, alpha methyl dopa. If blood pressure is not controlled in spite of labetalol IV, then you can start nitroglycerin drip. Antihypertensive contraindicated in pregnancy is inhibitors because they cause teratogenic effect. That is congenital malformation if given in first trimester. They cause placental insufficiency when given in second or third trimester. Okay. Next, what is the main role of antihypertensive in severe preeclampsia or eclampsia patient? Is to prevent abruptio placentae, postpartum hemorrhage, cerebral hemorrhage, or IUGR. What's your answer? Which is the main role of antihypertensive given in preeclampsia or eclampsia patient? Answer is to prevent cerebral hemorrhage. Prevent cerebral hemorrhage. This is the most important role of giving antihypertensive in cases of severe preeclampsia or eclampsia patient. Now 20-year-old primigravida was brought to casualty 34 weeks with severe headache. Blood pressure is 180/120. Doctor was examining, she threw on a fit. What is your first line of management? I want the correct answer in this question. Is it magnesium sulfate? Is it antihypertensive? Is it maintain the airway first? Or is it prepare for LSCS? What's your correct answer in this question? You have to give me this correct answer. What's your answer in this question? First line management in severe preeclampsia who has thrown a fit. Now it's a case of eclampsia. What's your answer? I would like to maintain the airway first because patient will be unconscious and tongue can fall back and she can aspirate the secretions and she can die. So always remember ABC: airway, breathing, circulation. Airway, breathing, circulation. This is very, very important. Next, 35-year-old female brought to the casualty with 5 convulsions at home. Blood pressure is 180/120. What's your management? Labetalol plus magnesium sulfate or immediate cesarean. This is very clear. I think most of you know the answer, labetalol plus magnesium sulfate. Now single liners. Safe therapeutic level of magnesium sulfate 4 to 7 milliequivalents per liter. What is the first sign of magnesium sulfate toxicity? First sign of magnesium sulfate toxicity is disappearance of knee jerk. What is the antidote of magnesium sulfate? Calcium gluconate. What is the choice of anesthesia for cesarean? Epidural. Maximum teratogenic anti-epileptic drug? Sodium valproate. Anti-epileptic of choice in pregnancy with least teratogenic effect? Levetiracetam. If that's not given in the option, then lamotrigine. Drug for raised intracranial tension in pregnancy? Mannitol. Drug for status epilepticus, thio, pentone, sodium. So all these questions have already been asked in FMG exam. So please go through. I don't know what exact will be the form of question, but I have prepared the gist of the whole subject, and definitely if you are here till the end, then you will get a maximum benefit, because most of these things are already there in mind, and I am giving you very clarity. Thank you, Dr. Shubham, for the appreciation words. Okay, so this is very clear. You should not mark anything else from whatever I am telling you with experience, because you might be writing your exam for the first time, but we as a teachers are not teaching you for the first time. Mannitol is not contraindicated in this case, because it is a cerebral edema, that is osmotic diuresis that you want. It is the loop diuretics furosemide which is not preferred in this case. Now, antepartum hemorrhage. So enough of pre-eclampsia and eclampsia. I have given you the single liners. I have added up all those questions which are important. Then I have already told you the hypertensive disorders classification. Okay, Dr. Aditi, I will try to explain you what you are asking me, that Rh antigen means presence of D antigen on the red cell membrane. If the D antigen is present, that means the person is Rh positive. If the D antigen is absent, that means person is Rh negative. So if there is an Rh negative mother and she is carrying an Rh positive baby, then her immune system will form the antibodies against these fetal RBCs and will cause destruction of these RBCs, and the baby will develop hydrops fetalis. That is why there is anti-D immunoglobulin injection which is given to an Rh negative mother who is delivered an Rh positive baby, so that if during delivery, if there are any fetal RBCs entered into maternal circulation, that will be neutralized by these antibodies. Okay. Thank you so much for the appreciation words, doctor. Now, antepartum hemorrhage is bleeding occurring after 28 weeks before the birth of baby. Okay, so you get an image based question. You can see that there is blood. There is blood behind the placenta and there is a placental separation, that is abruptio placentae. Here in this case you can see the low lying placenta, that is placenta previa. So you are asked image based question from this. Next, placenta previa. Name the expectant management of placenta previa, that is McAfee-Johnson's management. It is given to those patients who have come with painless causeless bleeding, mother vitals are stable, fetal heart rate is normal, there are no uterine contractions, and there is no active bleeding. Okay, so this is McAfee-Johnson's management. So they have asked image based question, like if the placenta is in the lower segment away from the os, that is type 1. If it is touching the os, that is called as marginal placenta previa or type 2. If it is covering the os partially, that is called as partial placenta previa, and this is complete placenta previa or central placenta previa, that is type 4, and this is called as low lying placenta previa. So in your exam they have asked the marginal placenta previa. So be clear, where is the lower limit of the placenta? If it is touching the os, that is type 2. If it is covering the os partially, it is type 3. If it is covering the os, that is type 4. Thank you so much, Dr. Aspiring, for your wonderful words of appreciation. Thank you everyone. For this way, the teacher feels more enthusiastic to bring up such an exciting sessions for you. Next, 35-year-old lady presented with G3P2L0A0, that is, this is a bad obstetric history, 2 deliveries and no live issue. 37 weeks of pregnancy, she has profuse bleeding. So pregnancy is already term, okay, and this is profuse bleeding. And there is central placenta previa at 32 weeks, that is a third trimester ultrasound showing central placenta previa. So the placental site will not change after 20 weeks. So what is your mode of delivery in this case, or what is your next line of management? Since the pregnancy is term, I am not going to wait for next bout of bleeding. It's a central placenta previa, that is a straightforward question. I am going to do an immediate cesarean section, but definitely I am going to arrange blood, because during the cesarean section there can be more bleeding. These patients are at risk of postpartum hemorrhage, because the lower segment is a neutral or passive segment which cannot contract. Okay, next. Placenta previa and abruptio placentae, there is a basic difference. Placenta previa, both are the cause of antepartum hemorrhage, that is third trimester bleeding. Third trimester bleeding. So here there is painless, causeless bleeding. Per abdomen, fundal height is equal to period of gestation. Fetal heart rate can be normal or decreased, and local examination there can be bleeding present, but per vaginum examination is contraindicated. Here it is pain, cause and bleeding, and fundal height is more than the period of gestation. Fetal heart rate can be decreased or absent. Okay, per vaginum examination is allowed. Okay, next. So in cases of abruptio, you should know what is covalent uterus, and management of abruptio is termination of pregnancy. Usually conservative management do not work. Okay, conservative management do not work. We usually go for a lower segment cesarean section. So usually in the questions the history is given, like a pregnant lady, there is history of fall, she is 36 weeks, there is pain, there is bleeding, and BP is 150 by 100. So remember, PIH is very important cause of abruptio placentae, and there is tender uterus written in the question. So that is abruptio placentae, tender uterus written, and that is abruptio placentae. Next. Next topic is complications of third stage of labor. That is very important topic. Okay, here you should read postpartum hemorrhage, you should read acute inversion of uterus, you should read perineal tear, I have been discussing in my classes. Then you should read retained placenta, you should read placenta accreta. This is what is the complications of third stage of labor. So blood loss after a normal vaginal delivery is 500 ml, after a cesarean 1000 ml. Most common cause of maternal mortality in India, postpartum hemorrhage. Most common cause of shock after delivery is postpartum hemorrhage. Postpartum hemorrhage can be primary or secondary. Primary means within 24 hours of delivery. It can be third stage PPH due to retained placenta. It can be true primary PPH. Secondary PPH is PPH occurring after 24 hours of delivery, within 3 months of delivery. Mind it, the definition of secondary PPH, remember, is after 24 hours of delivery, but within 3 months of delivery is a definition of secondary postpartum hemorrhage. Thank you, Dr. Ranbir Singh, for the words of appreciation. Thank you so much. Obstetrics is the last part I am discussing. Those who are asking class is till when? If you want, I can finish it just now, or if you want me to complete the slides, rest of the obstetrics you want me to take up? Yes. Next, identify this maneuver. This is manual removal of placenta under GA in OT, okay, for the retained placenta, that is for third stage PPH, okay, third stage PPH. Identify the type of placenta responsible for secondary PPH. This is AIMS PG question. What is this type of placenta you are seeing? What is the type of placenta you are seeing in this question? Battledore placenta, succenturica low, filamentous insertion, or fenestrated placenta? Here in this image you can see very clearly that there is a extra lobe of placenta, there is an accessory lobe. An accessory or extra lobe of placenta is succenturica lobe. Succenturica lobe causes secondary PPH. Filamentous insertion causes vasa previa. That is a type of APH. Next, single liners. A lady delivered a child and went into shock. This is postpartum hemorrhage, mostly atonic PPH. A lady delivered a child and went into shock, that is out of proportion of blood loss. This is acute inversion of uterus. A lady delivered a child and went into unexplained shock. Amniotic fluid embolism. When it is unexplained shock, like a patient delivered a child, she started gasping, cyanosed, breathless, hypotension, collapsed, then that is amniotic fluid embolism. Management of third stage PPH is manual removal of placenta under GA in OT. Most common cause for secondary PPH, retained bits of placenta, that is succenturica lobe. Okay. Next, first line drug for PPH management is oxytocin, because its onset of action is fast. Preferred mode and dose of misoprostol in PPH is sublingual 800 micrograms. Misoprostol is prostaglandin E1 tablet. B-Lynch sutures are applied for atonic PPH in the uterus. Atonic PPH in the uterus. Next topic of discussion is twins, a type of multiple pregnancy. Monozygotic twins, when single ovum is fertilized by single sperm, after that it divides into two. So the twins have same genetic characters, same HLA typing, and they are always of the same sex. Dizygotic twins, two different ova are fertilized by two different sperms, released in the same cycle. Okay, so their genetic characters are different, HLA typing is different, they may be of same sex or may be of different sex. Okay. Next, very important, the types of monozygotic twins. If the division of fertilized ovum occurs within 72 hours, it is diamniotic dichorionic. That means two amniotic cavities and they have separate placenta. If the division is occurring between 4th and 8th day of fertilization, two amniotic cavities and there is a single placenta. If occurring after 8th day of fertilization, monoamniotic, monochorionic, single amniotic cavity, two babies are developing and there is sharing a single placenta. So, there is risk of twin transfusion syndrome. After 13th day of fertilization, conjoined twins. Okay. So, most common type of monozygotic twins is diamniotic dichorionic, and remember, dizygotic twins are always diamniotic and dichorionic. They are having a single variety. Overall, which is the most common variety of twins? Dizygotic, which is diamniotic dichorionic, monozygotic is 20%. So, most of the time whenever they have asked a question on twins, it is from the types of monozygotic twins. Okay. Next, if the division of fertilized ovum takes place between 4th and 8th day of fertilization, name the type of monozygotic twins. This you are supposed to tell me what is this answer. What is this answer? Diamniotic dichorionic or monoamniotic monochorionic or diamniotic monochorionic or conjoined twins? What's your answer? Come on, write down in the chat box. Yes, it is diamniotic and monochorionic twins. You are very correct. Next, identify what is this maneuver shown in this case. This is internal podalic version in the second baby of twins, which is in transverse line. Internal podalic version is done only in one indication, second baby of twins transverse line, in operation theatre under general anesthesia. Now, important is the fetal skull and fetus in utero. Now, you are supposed to know the boundaries of vertex, boundaries of face, boundaries of brow. Plus, you are supposed to know the boundaries of anterior fontanelle and posterior fontanelle. Anterior fontanelle is bounded by frontal suture, coronal sutures and sagittal sutures, and closure of anterior fontanelle occurs at 18 months of age. Total number of fontanelles in intrauterine life are 6. When the baby is born, the baby has 2 fontanelles. Posterior fontanelle is closed at birth or up to 6 months. It is bounded by sagittal sutures and lambdoid sutures. So, many times the question has been asked on the boundaries of anterior fontanelle, which is called as bregma. Next, you can get a presentation like this and they can ask you a question that they give you an image like this and they can ask you what is this position of vertex. So, this is, you can see occiput in the left side. So, this is left occipito anterior, this is occiput right side, right occipito anterior, this is occiput posterior, left occipito posterior and right occipito posterior. And if it is in the transverse diameter, then it is called as LOT or ROT. These are the positions of vertex. So they can ask you an image based question like this. Next, identify what is this image showing and what is this image showing. You can tell me. You have to know what do you call it as denominator. Denominator. In cases of vertex, the denominator is occiput. In cases of face, the denominator is mentum. In cases of breech, the denominator is sacrum. So these denominators are used to describe the positions. Okay. Now what is this first image showing? This first image is showing the brow presentation. It is not vertex because occiput is behind. It is not face because mentum is behind. So this is this part which you see on the per vaginum examination. So this is brow presentation. It will not deliver, you have to do cesarean section because of the largest diameter, that is mento-vertical 14 centimeters, which cannot pass from maternal pelvis. The next presentation is face presentation. You can see this part, you can see this part. Okay, so occiput is behind, so it is not vertex, and the forehead is behind, it is the face, you can see the orbit. So this is face presentation. Anteroposterior diameter in vertex is suboccipitobrachmatic 9.5 centimeter. Normal vaginal delivery can take place. Mento-vertical is 14 centimeter. You have to do a cesarean section. Submento-brachmatic 9.5 centimeters. Normal vaginal delivery. So in vertex and brow, normal vaginal delivery can take place, but in brow you have to do cesarean because that is the largest diameter of fetal skull, which is the smallest diameter of fetal skull. Smallest diameter of fetal skull is bimastoid, that is 7.5 centimeters, and that is a transverse diameter of fetal skull. Next, Leopold's maneuver. When you do per abdomen examination, you apply the fundal grip, that is the first grip. You apply the lateral grip, that is the second grip. This is first, this is second, this is third. Third is a pollic grip, that is for presentation. Presentation can be cephalic, which is shown in this image, or it can be podalic, which is breech. And fourth grip is the pelvic grip, which is for engagement. So you can get this complete image and they can ask you what is this maneuver? Answer is Leopold's maneuver to describe the lie and presentation, and they can give you a second grip and they can ask you what is this grip? Answer will be lateral grip. They can ask you the third grip, that will be the pollic grip. So this maneuver is the Leopold's maneuver, and there are four grips: fundal grip, lateral grip, pollic grip and pelvic grip. What is this conjugate which we can measure clinically? Is a diagonal conjugate. That is the anteroposterior diameter of inlet, and it is 12 centimeters. What is the importance of ischial spine in the maternal pelvis? Importance of ischial spine in the maternal pelvis is here internal rotation of fetal head occurs. Here deep transverse arrest occurs in occipito-posterior position. Here levator ani muscle is attached. Here pudendal block anesthesia is given. So that is the importance of ischial spine. That is also called as zero station. That is also called as zero station when you see the descent of the fetal head. Fine. Next, normal pelvis in a female is gynecoid pelvis, this one. Then deep transverse arrest occurs in android, pelvis and even in anthropoid. But one answer to mark, it is android pelvis, question asked in MCI. Image based question of gynecoid pelvis has also been asked in MCI. Face to pubis delivery occurs in anthropoid pelvis because anteroposterior diameter is more than the transverse diameter. Next, normal labor, remember 3 P's: push, that is uterine contraction; passage, that is pelvis; and passenger, that is fetus. So, for a normal labor to proceed smoothly, there has to be a coordination between the push, passage and passenger. Push is the uterine contraction, passage is the maternal pelvis should be normal, there should not be any bony obstruction or soft tissue obstruction. At passenger should be the fetus, it should be an average size baby. Now, intrauterine pressure in first stage of labor is 40 to 50 millimeters of mercury. In the second stage of labor is 100 to 120 millimeters of mercury. In the third stage is 100 to 120 millimeters of mercury. Questions important for FMG exam. Now, this is partogram. Partogram is a graphical representation for stages of labor. In number 1, we plot maternal information, name, age, CR number, etc., date of admission, time of admission. Number 2, we plot fetal well-being, that is fetal heart rate and status of the fetal membranes. Number 3, labor progress, cervical dilatation and descent. There is an alert line, action line. Alert line starts from 4 centimeters of cervical dilatation. On x-axis we plot time, and in y-axis we plot the cervical dilatation and descent of fetal head. Then number 4 is medication, that is any oxytocin or pain relief you have given. Number 5 is fetal well-being, and in the labor progress there is uterine contraction. This dark circle, dark mark is showing good uterine contractions. So, this is a normal delivery. The line, there are 3 zones, zone 1, zone 2 and zone 3. If the graph is going in zone 1, that is a normal progress. If it is going in zone 2, that is a slow progress. And if it is going crossing the action line, then that is an obstructed labor. You have to do a cesarean section immediately. Okay. So, this is a normal progress. You can see in zone 1, the cervical dilatation has become 10 centimeter. The descent of the fetal head has occurred from 0 minus 0 plus 1 plus 2 plus 3, the baby is born. Here it was going in zone 2, but oxytocin was given, and now there are good uterine contractions and baby delivered. Prenatal diagnosis. Prenatal diagnosis, first trimester screening. You take the maternal blood markers like beta HCG plus PAPA. PAPA is pregnancy associated plasma protein. Beta HCG level rises and PAPA decreases, and you combine it with an ultrasound around 11 to 14 weeks and you check nuchal thickness. And if you combine these two, nuchal thickness more than 3 mm, that is abnormal, and markers are positive, this is Down syndrome. This is a first trimester screening and around 87% accuracy, but it has to be followed by chorionic villus sampling because you want to take the fetal sample for karyotyping. Next, identify the image. I have given you 2 karyotypes. What is this image showing? Karyotype 1 and karyotype 2. Write your answers in the chat box. What is this karyotype showing? What is this karyotype showing? This is trisomy 21, that is Downs, and this is trisomy 18, that is Edwards syndrome. Edwards syndrome. Next, quad test. Quadruple test is done around 16 to 18 weeks. It's a second trimester screening test. You take the maternal blood sample and you do the markers, alpha fetoproteins, beta HCG. Now we prefer doing quadruple test better than the triple test. So alpha fetoproteins, beta HCG, serum estriol and inhibin A. Alpha fetoprotein decreases, HCG rises, estriol decreases, inhibin A rises. These findings are consistent with trisomy 21. Okay. Next, what is this image of ultrasound showing? This is a frog eye sign on ultrasound, that is anencephaly. Anencephaly. Yes, rocker bottom feed is for Edwards syndrome, and quadruple test is basically done between 16 to 18 weeks. That is second trimester screening. Okay. Next, type of congenital heart disease in Down syndrome. Type of congenital heart disease in Down syndrome is endocardial cushion defects. Endocardial cushion defects, this is a Down's baby. Okay, the question has already been asked in FMGE exam. Now, MTP, next important topic. All the important content of gynae I have covered. Now I am covering the obstetrics, what are important and from where the questions are expected to be asked. Okay, a very detailed discussion of a topic is not possible when you are doing a rapid crisp fire revision of a subject. Okay, so MTP, medical termination of pregnancy. MTP is legal according to the latest MTP Act 2020 or 2021. It is legal up to 24 weeks. Okay, previously in MTP Act 1971, MTP was legal in less than 20 weeks. Okay. Now, opinion of how many doctors needed for MTP. Opinion of one doctor needed when you're doing MTP up to 20 weeks. Opinion of two doctors needed when you're doing MTP between 20 to 24 weeks. Question asked in FMGE exam. Okay. Question asked in FMGE exam. Next. Who all can do MTP? Who all can perform MTP? A registered medical practitioner who has assisted 25 MTP in government approved authorized center. Question of FMGE exam. A doctor who has done 6 months of house job in OBS and Gynae can perform MTP. A doctor who has done MD, MS, DGO or DNB in OBS and Gynae can perform MTP. So you should remember this. If any pregnancy grows beyond 24 weeks and it's a special case like rape victim, can MTP done? In that case goes to a medical board which consists of a gynecologist, pediatrician, radiologist and a gazetted officer appointed by the state government. And if they approve yes, MTP can be done, then doctor is supposed to perform the MTP. Next. All of the following are important indications for MTP except condom failure, rape victim, mother having serious medical disease or large family size, which is not an indication for MTP. Come on, write down in the chat box, which is not an indication for MTP. Which of the following is not an indication for MTP? I can read your chat box. Yes, so it is large family size which is not an indication for MTP. Next, medical abortion by tablets. Mifepristone, that is RU 486, which is anti-progesterone. 200 milligram oral is given This is followed 48 hours later by misoprostol, which is prostaglandin E1, 800 micrograms vaginal. This is followed by abortion. So, mifepristone followed by misoprostol, and MTP can be done by this method up to 9 weeks. Okay, up to 9 weeks. Next, abortions. Now, in abortions, if there is history of amenorrhea, bleeding per vaginum, on examination, cervix is closed, bleeding is present, size of the uterus is equal to period of gestation, then that is called as threatened abortion. You can get an ultrasound done to check for the cardiac activity. If cardiac activity is present, you can save the pregnancy by giving progesterone support. Okay, this is very commonly asked question. Number 2, if the cervix is open, bleeding is present, product of conception felt, size of the uterus is equal to period of gestation, then that is inevitable abortion. You cannot save the pregnancy, you have to do DNE. If cervix is open, bleeding is present profusely, POCs hanging out in vagina, size of the uterus less than period of gestation, that is incomplete abortion, and management is DNE. If they have to ask a clinical question in the topic of abortion, they will ask you either threatened abortion or inevitable abortion or incomplete abortion, and they can ask you management or they can give you clinical findings. If the size is less than period of gestation and there is bleeding heavily, products are felt, then that is incomplete, management is DNE. If products are felt but not expelled, size is equal, then that is inevitable. If no products felt, cardiac activity present, cervix is closed, then that is threatened abortion. You can save that pregnancy. 25-year-old female, this is an FMGE exam question. 8 weeks amenorrhea, bleeding per vaginum, cervix closed, bleeding present, size of the uterus corresponding to period of gestation, cardiac activity present. What is the type of abortion in this case? This is threatened abortion, and you can save this pregnancy because cardiac activity is present, baby is alive, and you can save this pregnancy. Next, most common cause for first trimester abortion is chromosomal. Which type? Trisomy is the most common cause. Most specific is monosomy. Most common cause for second trimester abortion, cervical incompetence. Okay. Next, 30-year-old female, G5P1L0, that is bad obstetric history. This is her 5th pregnancy, 1 was a stillbirth and 3 is abortions. She had 13 weeks, 11 weeks, 9 weeks abortions plus a preterm delivery. This is antiphospholipid antibody syndrome. Classical presentation of abortion less than 10 weeks, abortion more than 10 weeks, and a preterm delivery. So, all these 3 are present. This is antiphospholipid antibody syndrome. Antepartum, intrapartum fetal surveillance biophysical profile. Biophysical profile, it is a special ultrasound done in high risk pregnancies. You check non-stress test, amniotic fluid, fetal tone, fetal breathing movement, and gross body movement. To each parameter you give 2 score. Normal score is 10/10. What is modified biophysical profile? is when you're doing only NST and amniotic fluid index by ultrasound, that is called as modified biophysical profile. What is this machine? This is NST machine. What do you understand by NST? NST is done in high risk pregnancies like preeclampsia, like IUGR, like diabetes in pregnancy, like post-dated pregnancy, etc. And this is relationship of fetal heart rate to fetal movement. Okay, you check 4 fetal parameters, that is baseline fetal heart rate, which is 110 to 160 beats per minute, beat to beat variability, presence of acceleration and no deceleration. You can do NST at weekly intervals or bi-weekly intervals. This is an assurance that baby is going to be fine for a week or bi-weekly. Okay. So this is fetal movement, and you can see the acceleration of fetal heart rate. So baseline fetal heart rate is near about 130. You can see beat to beat variability 130, 140, 120, 130. You can see acceleration. So 2 or more accelerations present, and you take a recording over 20 minutes. So this is a normal reactive NST. Now CTG is done when your patient goes into labor. This is relationship of fetal heart rate to uterine contractions. Okay, so you can see this is uterine contractions and this is fetal heart rate. Nothing happens to fetal heart rate in a normal CTG. Okay, now head compression causes early deceleration. This is important. Cord compression causes variable deceleration. Chronic placental insufficiency causes late deceleration. So head compression, you can see early deceleration here. With uterine contraction, there is dip of the fetal heart rate. Fetal heart rate is dipping. This is early deceleration. Due to uterine contraction, if fetal heart rate is dipping after the contractions, that is late deceleration. If it is not related with uterine contraction, any time dip can be seen. That is variable. So either there will be an image based question or there will be head compression, cord compression or chronic placental insufficiency. They can ask you this way. Next, physiological changes during pregnancy. Next topic. Weight gain during pregnancy according to Williams 12.5 kg. Otherwise you can mark 11 to 13 kgs. Most common cause for maternal mortality in India is postpartum hemorrhage. Most common indirect cause for maternal mortality, anemia. BMR increases in pregnancy 25%, although TSH, T3 and T4 remains the same. It is the alpha unit of HCG that behaves like TSH because it is structurally and functionally similar to TSH. Okay. Breast changes mammogenesis is caused by estrogen and progesterone. Lactogenesis is caused by prolactin. Galactokinesis is milk ejection reflex caused by oxytocin. Galactopoiesis is maintenance of lactation. Okay, so remember this. Maximum cardiac output seen during pregnancy is immediate postpartum. Immediate postpartum cardiac output is 70%. During labor, cardiac output is 60%. During pregnancy, 30 to 32 weeks, cardiac output is 50%. So maximum cardiac output is seen immediately after delivery. Cutoff value for hemoglobin to label it as anemia in pregnancy according to WHO is 11 gram percent. According to India is 10 gram percent. HCG is a glycoprotein secreted by syncytio trophoblast. Doubling time is 48 hours. Question from FMGE exam. Testosterone is secreted by Leydig cells in males and inhibin is secreted by Sertoli cells in males. Okay, inhibin is secreted by Sertoli cells in males. Testosterone Leydig cells secrete as early as 7th week of intrauterine life. This testosterone is responsible for external and internal genitalia formation in the male fetus. Okay, Sertoli cells secrete Mullerian inhibiting substance that inhibits the Mullerian duct in the intrauterine life so that males do not have uterus. So, inhibin is secreted by Sertoli cells, question of FMG. Testosterone is secreted by Leydig cell, question of FMG. Now, this pink is the Mullerian duct and blue is the Wolffian duct. If there is testosterone in the intrauterine life, then it forms the internal genital organs in the males, that is epididymis, vas deferens, ejaculatory ducts and seminal vesicles are derived from Wolffian duct in the males, and the hormone necessary for this development is testosterone, which is secreted by the Leydig cells. Gonads, ovary and testis are derived from genital ridge. Lower vagina arises from urogenital sinus. Lower vagina arises from it should be pap smear to be done first, followed by colposcopy depending upon the pap smear report. Okay. Next, uterus, cervix, fallopian tube and upper vagina. See, if there are no testosterone, that means the gonad is not testis, it is ovary. So, there are no Sertoli Leydig cells, so no testosterone. Then Wolffian duct regresses and forms the remnants, which is apophoron, paraphoron, and Mullerian duct forms uterus, cervix, fallopian tube and upper vagina. So, Mullerian duct derivatives are uterus, cervix, fallopian tube and upper vagina. Lower vagina arises from urogenital sinus, gonads derived from genital ridge. Male pseudohermaphrodite, can you give example? It is androgen insensitivity syndrome or testicular feminization syndrome and also Swyer syndrome. Female pseudohermaphrodite is congenital adrenal hyperplasia. Karyotype is 46XX. Here it is 46XY. Here it is 46XY. So, here the gonads will be undescended testes. Here the gonads will be ovaries. Now, there is a difference between a septate uterus and a bicornuate uterus, and these are the HSG findings. Remember, in case of septate uterus, this angle is acute angle 75 degrees. In bicornuate uterus, angle is obtuse angle between the two horns. Okay. This is a septate uterus and the investigation gold standard is hysteroscopy because you can do resection of the septum. In case of bicornuate uterus, you can go for laparoscopy and laparoscopic guided metroplasty repair. okay, metroplasty, because septate uterus and bicornuate uterus are the important causes for infertility. It can be an important cause for habitual abortions. So treatment should be taken if it is causing recurrent abortions. Okay. Next, this is an HSG. This is an image based question being asked in FMGE exam, and you can see unicornuate uterus. Unicornuate uterus. Now, according to DIPSI criteria, diabetes in pregnancy study group, and according to the national guidelines, universal screening for gestational diabetes should be done in all pregnant ladies. First time is at first antenatal visit, and second should be repeated at 24 to 28 weeks. No fasting is needed. You give 75 grams of glucose and you should take blood sugar levels after 2 hours. Cutoff value should be less than 140. And on this, many times a question is being asked in the FMG exam. Okay. If it is a two-step criteria, you give 75 grams of glucose, you take fasting sample 92, after 1 hour, 2 hours, it should be 140 and 153. Okay. So this is 92, 180 and 153 also you should remember. Now what is this condition associated with? What do you see? It is caudal regression syndrome or sacral agenesis. This is seen in pre-gestational diabetes because gestational diabetes is developing after 20 weeks. Organogenesis is already complete, so there are no congenital anomalies if it is gestational diabetes. Okay. Next, what is this maneuver shown? This is a Mac-Roberts maneuver shown for a case of shoulder dystocia. Shoulder dystocia is a complication seen in a macrosomia baby. Macrosomia baby, you should do an elective cesarean section, but if the patient is unbooked and she has just come to you for delivery, the shoulders get stuck up and this lands up in shoulder dystocia. So Mac-Roberts maneuver is been done. This is filamentous insertion of placenta, and this can lead to a condition called as vasa previa, that is a type of APH, and the blood she is losing is of fetal in origin. So maybe the baby is born as very pale. Now some of the important questions towards the end of this session. I am just winding up this session. Okay. Now, a 35-year-old female brought to the casualty in collapsed state. There is history of amenorrhea 1.5 months, bleeding and fainting. So, amenorrhea, bleeding, fainting, BP 80/40, ultrasound done, no gestation sac in the uterus, free fluid in pouch of Douglas, resuscitation started. What is your diagnosis? This is a ruptured ectopic pregnancy because amenorrhea 1.5 months, that is 6 weeks amenorrhea, pain, bleeding, fainting, in shock. So I am going to perform immediate laparotomy. Okay, I will start the resuscitation first, followed by laparotomy. I have already discussed in the beginning of this session. Next, a lady presents with thin frothy discharge and red vagina. Saline microscopy, motility is seen. What is this motility? This is a trichomonas vaginalis infection. Okay. So I am taking up some of the latest questions so that you know what type of questions are being asked. Pipelle is an instrument used for endometrial sampling. I have already discussed. So I am just winding up this session. Dysmenorrhea with a tender uterus. Dysmenorrhea with a tender uterus is always adenomyosis. Most important indication for surgery in uterine anomalies is always when there is a history of recurrent abortions. That is, habitual abortion is a most important indication for uterine anomaly surgery. Karyotype incomplete mole. So, in the topic of genital tract cancer, the trophoblastic tumors was left, so I decided to add up in the single liner form. Karyotype of complete mole is diploid and partial mole is triploid, and the abnormal chromosomes are paternal in origin. Investigation of choice to diagnose molar pregnancy is ultrasound, and you see snow storm appearance. Most common gestational trophoblastic tumor developing after H mole is residual mole. Treatment for H mole occurring in young female is suction, evacuation. Most common site of metastasis in choriocarcinoma is lungs. X-ray chest finding of choriocarcinoma shows cannon ball appearance. Drug used to treat choriocarcinoma is MAC regime, that is methotrexate, folinic acid, actinomycin D and cyclophosphamide. Identify the given image shown. So, the placenta is low lying and it is just touching the internal os, do not cover it. So, this is marginal placenta previa, that is type 2 placenta previa. Primi gravida given birth to a male child without any issues, the mother or the infant. How many hours the breastfeeding should be started? As early as possible, so within 1 hour. RH negative, Dr. Neha, I have already explained it. Detailed discussion will not be possible in this revision session. So, identify this forceps. This is an outlet forceps. Outlet forceps is called as Wrigley's forceps. Wrigley's forceps. Which of the following is not a contraindication for normal vaginal delivery? Previous to LSCS, you will do an elective cesarean section. Previous classical cesarean, you will do elective cesarean. No way that you can allow for a normal vaginal delivery. Contracted pelvis, again elective cesarean. Previous macrosomia, this time it is not an indication you can allow a normal vaginal delivery. Order of lochia. Lochia rubra, serosa alba. Lochia is shedding of decidua and this is 21 days. 52-year-old female presented with abnormal uterine bleeding for 4 months. AUB. What should be your next step in management? Mirena, progesterone, endometrial aspiration or plus endocervical curettage or hysterectomy. I want you to mark this answer. 131 students are attending this session. So, please tell me what is the correct answer, because this is an expected question. So, this series, whatever is my judgment, most of the things will come from this session. That is just an experience of taking classes for so many years. So, answer to this question is endometrial aspiration, because you want to rule out endometrial cancer in this case. Dose of elemental iron and folic acid in pregnancy is 60 milligram of elemental iron and 0.5 milligram of folic acid. All of the following are markers for triple test for Downs except beta HCG, alpha fetoprotein and estriol. Estradiol is not the marker. Identify the presentation. What is this presentation? Mark your answer. I have already discussed this particular part. Come on. What is this answer? This is, my friends, this is a, what is this? This is a bra presentation. You can see mentum behind, you can see occiput behind. This is bra. Identify the grip, fundal, lateral, pollic or pelvic. What's your answer? Yes, this is a lateral grip, and this maneuver where we apply these grips are Leopold's maneuver. Just after delivery, uterus is at what level? It is just below the umbilicus, that is corresponding with 20 weeks. Okay. So friends, this is all I have to discuss in this session. Hope this session was useful to you. Just revise the topic of genital prolapse, urinary fistulae, and you can grow through the videos if you have time. I have already discussed in the guest series session, in the 5 years PYQs, in the test and discussion for FMG batch. So you can go through that. So that's all, and all the best for your upcoming FMG exam. Do your best, and exam 4 दो. OBS Gynae की preparation आपकी already बहुत ही बढ़िया है, because whatever I can get your feedback, you're attending the session in large number, 135 plus students. So all the best. Yes, cancers are very, very important. Cancer cervix, Dr. Aditi, I have already covered up in detail. So thank you so much for attending the session, and hope this session is useful to you. All the very best for your upcoming exam.